Happy to have you all back on day 2 of Tanpsycon-2022. So we're moving on to the first session. Professor A. Venkoparao oration. I welcome the chairpersons, immediate past President IPS, Professor Dr. Kumanan, over to the dais. I also welcome current President IPS, Professor Dr. Malayappan, over to the dais.
Good morning all. I welcome you all for the second day's session of our state conference, 37th state conference, and we are on a very important program here. It's a prestigious Professor Dr. A. Venkoparao Oration Award. It has been present for the past 8 to 9 years, and it's a very prestigious one considering our society's functions. And I invite Dr. Sabita, Awards Committee in charge, to highlight about this, and we'll start the session now. And we are very happy to
we are happy to announce that AVR oration is delivered by Dr. R. Satyanathan. We are thankful to him for accepting that.
To introduce Professor AVR, அது எப்படி சொல்கிறதுன்னு தெரியல. அதாவது செல்லிங் கோல் டு நியூ கேசல்பாங்க. அவர் தெரியாத ஆளே இல்லை. ஏன்னா if all the newcomers you can see in the ICD-9, ICD-10 in the contributors list, his name will be there along with the name of the place, Madurai. He has brought our psychiatry, our state and as well as the national psychiatry into the international map through his contributions. He was the founder of our department, and he started PG courses in 72 and 77, and almost all the southern senior psychiatrists currently practicing are his students. Almost. It is not a boasting, it's a reality. And I am fortunate to be an undergraduate student under him. I have attended his classes, theory classes in my L4 classroom, as well as his clinical demonstration in the Department of Psychiatry. And when I became a PG, he had retired and he was carrying out research work in ICMR. So we used to meet him regularly, and I'm very happy to have interacted with him in our first South Zone conference at Madurai. I was the Savanir in charge, and during the banquet in 2000, he was conversing, he was chatting with all his students in a happy moment. Someone introduced me saying that he has been in charge of the Savanir, and he just caught hold of me. He shook hands with me and told me that the Savanir cover is excellent. That year's theme was Dare to Care. So I had just pictorially depicted the Philip Penel Unchaining and others, Sigmund Freud, and other one more small clip. So he said, you are right. Psychiatry is in two phases. One is before Freud and after Freud. You are correctly depicted. I consider that to be a very memorable occasion for me. And on the completion of that event, and we all, the old students of the Department of Psychiatry, felicitated Professor AVR, and that was materialized by our Professor CRS in the same venue, and everybody were given compliments with the hand, from the hands of this AVR. I preserve it. So, and coming to the academic session, almost everyone knows about his contributions. Innumerable papers. Wherever you see, even in IJP, BJP, AJP, you can see lot of publications in the name, and his area of interest were geriatric psychiatry. And lithium, they did a pioneer study. He has authored many books, and he was also interested in suicide, study of suicide. Even when we were students, our classmates used to go for as volunteers for getting involved in the study, for collecting blood samples early morning for this depression, this cortisol levels. My classmates in 84, what I'm telling is 83, 84, 1983. So we can go on talking about AVR, and I was very much surprised when I was assistant professor. Our students went to Kerala one-day seminar for bipolar disorder, and they were very much surprised to know about the respect that the Kerala psychiatrists were giving to our professor. I still remember they had a session regarding AVR in bipolar. So my students were very much surprised, and he was telling the current organizing chairman was that person. Dr. Ananda Krishna Kumar used to tell me, sir, AVR pati ivvalavu respect vechirukkranga Kerala. All the senior psychiatrists who used to come as examiners for us. So he had left an indelible mark in the history of psychiatry of the southern states. So in the award history, one of his student, our late professor Dr. Tyagarajan, Karandai Tyagarajan, we used to call him as MGR for our society. He had installed that award by contributing a huge amount in the name of his teacher. So it shows the magnanimity of the teacher as well as the student. So it is a prestigious award. Every year it is delivered by a prominent and eminent psychiatrist of our society. This time it is Dr. Satyanathan, and now Madam will introduce about it, and few words from Dr. Malayapan, current president.
I request our awards committee chairman, Professor Dr. Sabida, to introduce our versatile, dynamic orator, Professor Dr. Satyanathan, and we are very happy to hear from Dr. Satyanathan's speech.
I think Dr. Satyanathan requires no introduction. And he is eminent psychiatrist and a senior psychiatrist, and is currently running a memory clinic in Ananagar. And previously he has worked as professor, HOD and senior consultant psychiatrist at Sri Ramachandra Medical College and University, Porur. He headed the geriatric care clinic at Sri Ramachandra Medical Center, Porur, and he was the previous director of the Institute of Mental Health in the government of Tamil Nadu. Dr. Satyanathan attained master's degree in psychiatry from the reputed Madras University and his master's in public health from the University of North Carolina. He is a visionary who advocates development in the area of mental health in the country. As a director, clinical epidemiology unit, MMC and GGH Chennai, he has hands-on experience in organizing and coordinating several national and international multi-centric research projects and leading research teams. I think now also he is heading that. So we invite you, sir. I think we can give great hands to him.
Professor Dr. A. Venkobarao Oration Award, instituted by Indian Psychiatric Society, Tamil Nadu chapter, presented to Dr. R. Satyanathan at the 37th Annual State Conference of Indian Psychiatric Society, Tamil Nadu chapter, held at Kodaikanal on 9th of July 2022. Our salutations to former Director, Institute of Mental Health, Chennai, with 30 years of experience, immaculate service in Tamil Nadu government, retired professor and head of the Department of Psychiatry at Sri Ramachandra Institute of Higher Education and Research, Chennai. Emeritus Professor, Psychiatry, Academic Council Member, the Tamil Nadu Dr. MGR Medical University. President, IPS South Zone in the year 2008. International Member, American Medical Psychiatric Association in the year 2007. Member, inclined to Incline Trust International, received fellowships, grants for research work. Evolved as a pristine medico and a humane psychiatrist from Madras Medical College. Awarded Master of Public Health from University of North Carolina, USA. Governing body member, Alzheimer's and Related Disorders Society of India. University's Best Teacher Awardee, Senior Consultant Psychiatrist at the Memory Clinic in Chennai. He has passionately cared for the elderly. He cares them and he will care them.
I invite Professor Dr. Satyanathan to deliver his oration. Over to you, sir.
Good morning to every one of you here. I deem it a great privilege and honor conferred upon me by the Indian Psychiatric Society, Tamil Nadu branch, to deliver the oration during Tanpsycon-2022 in the fond memory of our great teacher, philosopher, mentor, and doyen of psychiatry, Professor A. Venkoparao. When we think of Professor AVR, two things come to our mind: Bhagavad Gita and elderly. Precisely, that is the reason why I have chosen this topic on geriatrics, with all due respects and appropriateness of our Professor AVR. People worldwide are living longer. The longevity has increased. The mortality rate, it was at 47, now it has come to about elderly living up to 64 years and all these things. Every country in the world is experiencing growth in both the size and proportion of older persons in the population. By 2030, 1 in 6 people in the world will be aged 60 years or over. This, what is called the demographic transition, this shift known as population aging that started with high-income countries is now transmitting to low and middle-income countries. Beyond biological changes, aging is often associated with other life transitions such as retirement, relocation to more appropriate housing, death of friends, death of spouse, and emergence of several complex health conditions that are commonly called as geriatric syndrome. That is the reason why I said that the elderly, the path was smooth and fine, and when they reach 60, 65, they reach a point at which they are at crossroads. Any number of us, all of us here, witness people who are coming here, elderly people, not everybody is being taken care of and all these things. If you look at all the risk factors in old age, common conditions in old age include hearing loss, cataracts, osteoarthritis, diabetes, hypertension, cardiovascular disorders, cerebral vascular accidents, and cancer, etc. Apart from these physical illnesses, many elderly are also at the risk of falls, reduced mobility, chronic pain, bereavement, fall in income, social isolation, neglect, and abuse, increasing their risk of developing mental health problems such as dementia, depression, anxiety, and substance use disorders. According to WHO 2017, approximately about 15 to 20% of the people over the age of 60 years suffer from one sort of a mental illness. Most of the family members and caregivers fail to recognize the early symptom of depression or dementia and do not seek mental health services. Tata dana marandiruvaru, paati dana maranditaanga, like that. Even our health professionals do not have adequate training to identify the early signs of possible mild cognitive impairment and preclinical Alzheimer's disease. Many of the early symptoms such as confusion, misplacing items, memory impairment, poor judgment, and withdrawn behavior are taken as normal process of aging. Moreover, most of the elderly are taken care of in multi-generational Indian families, and those with dementia do not get a proper diagnosis, treatment, or support. Also, the early memory disturbances are addressed more emotionally by the immediate family members rather than seeking professional help. Many do not help or utilize the existing medical care services during the early stages of Alzheimer's disease, but seek help only when the disease becomes chronic or unmanageable at home. It is estimated that nearly 50 million people worldwide are living with dementia, and it is projected to increase to 82 million in 2030, which is not far away. As per WHO, nearly 7.7 million new cases are added every year. India is expected to have more than 150 million older adults by 2025, where over 4.51 million elders are already living with dementia, and sadly, only 10% of the dementia patients get diagnosed. Added, some of the other contributing factors adding to the gravity of dementia problems are significant economic issues in terms of direct cost of medical and informed care and stress to carers and families. Wherefore, there is an urgent need for early diagnosis, prompt medication, and long-term care for sufferers and caregivers. It is also very important that we need to train and sensitize our health workers, health professionals, caregivers, and community to understand and recognize early cognitive impairment and the nature of illnesses. The health workers and health professionals should also be trained to note down activities of daily living and behavioral problems, physical illness, psychological distress, caregivers issues, and assessment of social and financial problems. The World Health Assembly in 2017 has endorsed the Global Action Plan on the Public Health Response to Dementia 2017 to 2025, envisaging on increasing awareness, dementia-friendly initiatives, reducing the risk for dementia, treatment, care, research, innovation, and support for carers. Cognitive abilities, you should understand, it changes with age. Cognition means requiring and processing information about ourselves and about the world. The cognitive abilities peak when you are in 30s and it starts slowly declining by the time you reach the age of 70 years. This cognitive decline affects the processing speed, selective attention, naming, executive functions, logical analysis, and cognitive flexibility. It is a slow process and may take 15 to 20 years before it manifests as dementia, because only at that time we recognize dementia. It is also a challenge to understand the transition from age-associated memory impairment to mild cognitive impairment and then to dementia. Therefore, it is of vital importance to focus on preclinical Alzheimer's or mild cognitive impairment. MCI, or what is called a mild cognitive impairment, is a brain function dysfunction or impairment beyond those expected based on age and education of the individual. However, it does not interfere with their daily activities. Even on long-term follow-up, only around 18% of the people with MCI ultimately progress to dementia, whereas dementia is an age-related disorder. It's a degenerative syndrome with a disturbance of memory, thinking, learning, language, abstraction, and judgment, ultimately affecting the mood and personality of the individual. In the initial stages of dementia, the short-term memory is affected. It may present with difficulty in new learning, forgetting recent conversation, forgetting appointments and important dates, misplacing and losing things, and forgetting recent events. But at a later stage, the long-term memory is also affected, such as forgetting past events, loss of highly learned skills, loss of personal information, tendency to repeat or confabulate. It is at this stage they tend to lose the sense of direction and orientation, and many begin to wander and go missing from their houses and institutions. As the disease further progresses, there will be difficulty in naming objects, decrease in speed output, develop inability to read and write, unable to perform motor activities such as dressing, writing, cooking, or driving, as also disorientation in place, person, and time. Inability to recognize faces, unable to plan with decreased judgment and reasoning. It is at this stage they also develop what we call BPSD, that is behavioral and psychological symptoms of dementia, such as aggression, sexual disinhibition, wandering tendencies, delusions, hallucinations, and anxiety symptoms. Some of them get depressed or develop manic symptoms and manifest focal neurological signs and extrapyramidal symptoms. But if you take the clinical syndromes of dementia, in Alzheimer's, there is a gradual onset of multiple cognitive difficulties. However, in vascular dementia, there will be an abrupt onset, fluctuating course, hypertension, and focal neurological signs. However, in Lewy body dementia, there are marked psychotic symptoms and behavioral disturbances, and the memory loss may not be the early symptom. However, there will be mixed presentation in frontal lobe dementias. And then I'm going to talk about biomarkers in dementia, because I was mentioning it is very important we need to understand and identify mild cognitive impairment, or what you call a preclinical Alzheimer's. Accuracy of diagnosis may be improved by the use of blood, CSF biomarkers, and neuroimaging. Structural neuroimaging will detect vascular changes and pattern of cerebral atrophy. Functional imaging, however, will confirm neurodegenerational and subtypes of various types of dementia. Intracellular neurofibrillary tangles, what you call NFT, containing hyperphosphorylated tau protein and apolipoprotein E, and extracellular senile plaques containing many proteins including beta amyloid, synuclein, apolipoprotein E, presenilins, are considered pathological hallmarkers of Alzheimer's dementia. Therefore, an early diagnosis with a reliable biomarker is the need of the day. The CSF biomarkers beta amyloid 42, T-tau, and P-tau are useful for diagnosis of early dementia. Amyloid PET scans reflect neuritic plaques burden and identify early pathological changes in Alzheimer's dementia. However, diagnostic accuracy decreases with age because AD-type pathology is also found in those people who are non-demented. So, imaging, CSF, and blood-based biomarkers have the potential to improve the accuracy by which the specific cause of dementia can be diagnosed in vivo, provide insight into the underlying pathophysiology. We have to accept that the analytical validity of the AD biomarkers do really exist. But however, its clinical utility has not been fully proven. However, the analysis of CSF and neuroimaging will throw more light on the neuronal loss, protein deposition in the preclinical stage of Alzheimer's disease, and the development of disease-modifying treatment approaches. What is more helpful is sometimes what we call a neuropsychological assessment of dementia. The neuropsychological studies show that cognitive deficits associated with Alzheimer's disease are different from age-associated cognitive decline. The differences are apparent in many cognitive domains, but are more obvious in episodic memory, semantic knowledge, and some aspects of executive functions. Neuropsychological assessments are designed to identify the extent and severity of an individual's cognitive impairment. These standardized tests are used to evaluate or assess cognitive abilities such as attention, memory, language, processing speed, visuospatial, executive functions. There are a lot of commonly executed cognitive screening tools that include MMSE, MoCA, Addenbrooke's Dementia Rating Scale, Philadelphia Brief Assessment Scale, ADAS-COG, that is Alzheimer's Disease Assessment Scale Cognitive. This test focuses on attention, language, orientation, executive function, and memory skills. Clock drawing test, neuropsychiatric inventory, the trial making test, Tower of London test, Wisconsin card sorting test, continuous performance test, and Stroop task test. In fact, I remember that when I think Nambi went to Osaka, then it's a beautiful dementia care center, and then one of them was mentioning the clock drawing test is the best test. You need not have cumbersome like CAMDEX or geriatric mental scale, which will take so many hours and all these things. That if you ask the person to do a clock drawing test, even you can find out the early symptoms of Alzheimer's and all these things. That the treatment approaches in dementia, to date, it's very sad, the existing treatment approaches are only symptomatic. What we now use is cholinesterase inhibitors. Cholinergic hypothesis of Alzheimer's disease focus on loss of acetylcholine neurons and synthesis of acetylcholine, resulting in cognitive dysfunctions. So, a strategy to enhance the cholinergic transmission is to use cholinesterase inhibitors. There are 3 approved cholinesterase inhibitors for the treatment of mild to moderate Alzheimer's. They are donepezil, rivastigmine, and galantamine. Many double-blind RCTs have shown that these drugs showed benefit of cognitive functions, activities of daily living, and global functions for patients with dementia. The incidence of adverse effects such as gastrointestinal side effects, they were lower with donepezil than with rivastigmine and galantamine, especially with a higher therapeutic dosage. The dermal form of rivastigmine provides with a lower dosage and with a fewer side effects. The meta-analysis of all these clinical trials showed of cholinesterase inhibitors showed that they delay the decline in cognitive functions as measured by the AD assessment scale and behavior of an ADL over 6 to 12 months. The symptoms that improved include attention, memory, language, and communication. In moderate to severe dementia, memantine is believed to protect neurons from excitotoxicity. A systematic review of RCT studies of memantine showed improvements in cognition, ADL, and behavior in moderate to severe AD after 6 months of use. It also reduces behavioral and psychological symptoms of dementia. RCT studies on parallel groups of patients with moderate to severe dementia showed significant benefit in cognitive functions and behaviors from the combined use of memantine and donepezil over the placebo group. And the BPSD are the reasons for increased caregivers' burden and institutionalization. They may present with psychosis, aggression, and apathy. SSRIs are largely considered to be the effective antidepressant for mood symptoms. Other widely used antidepressants are mirtazapine, duloxetine, and venlafaxine. Atypical agents such as risperidone, olanzapine, quetiapine, and aripiprazole are the preferred antipsychotics in Alzheimer's disease with BPSD. Further, benzodiazepine will definitely reduce agitation and anxiety, but we know that sometimes it can trigger agitation in elderly. According to amyloid hypothesis, the beta amyloid protein production in the brain initiate what we call amyloid cascade of amyloid. Initiate a cascade of events leading to Alzheimer's. The elements of cascade include local inflammation, oxidation, excitotoxicity, and tau hyperphosphorylation. Hence, novel treatments under development aim to interfere with this pathogenic process and is the reason why they are called disease-modifying drugs. Both beta amyloid and tau are prime targets in disease-modifying therapies in AD. The only beta amyloid aggregation inhibitors reaching phase 3 trial was a synthetic drug, the tramiprosate, which are designed to interfere with the binding of glycosaminoglycan and beta amyloid. Another molecule undergoing test is what is called colostrin. It is derived from sheep colostrum, which inhibits beta amyloid aggregation. But however, phase 2 trials only demonstrated modest improvement in MMSE scores. Also, there are several chelators of zinc and copper. They have shown to inhibit beta amyloid aggregation, as PBD2 is a compound that affects the copper and zinc mediated toxic oligomerization of beta amyloid. Further, there are several selective beta amyloid lowering agents. The dominant pathway in AD, as all of you know, is the cleavage of APP by beta secretase followed by gamma secretase. So, by inhibiting beta secretase and gamma secretase, beta amyloid production may be reduced. Accordingly, our hope is that the development of BACE1 inhibitor therapy, which is a promising target, although only a few beta secretase inhibitors have entered clinical trials up to date. Unfortunately, 2 large phase 3 clinical trials on gamma secretase inhibitors were prematurely stopped. I was one of the persons who has been taking part of this international trial, and as we started that, some of the patients developed hepatocellular carcinoma and then myocardial infarction, and we had to stop the trials and all these things. So, the other one, next is people who are trying immunotherapy. The idea is for amyloid clearance by immunotherapy, where active immunization like vaccination and passive immunization by using monoclonal antibodies are studied. Although the phase 2 vaccination trial was discontinued, few trials have used monoclonal antibody businozumab in phase 3 trials and solanezumab in phase 2 trials. There are drugs interfering with tau deposition. Phenothiazine, methylene blue, was being evaluated in Alzheimer's disease clinical trials, but unfortunately it has to be stopped because when the patients were passing urine, it was bluish in color, and so the blinding was revealed, and so they had to stop these clinical trials. More so, multiple drugs like kinase inhibitors, such as potential therapeutic targeting tau and anti-inflammatory drugs like NSAIDs, protect against non-steroidal anti-inflammatory drugs, protect against Alzheimer's disease. Several antioxidants have been tried, like vitamin E, ginkgo biloba, green tea, blueberries, and our curcumin were tried. Some of the studies have shown that statins, that the cholesterol-lowering drugs, be beneficial to patients with mild to moderate Alzheimer's disease. See, there are any number of, more than thousands of molecules are being tested, but nothing reaches the phase 3 trial because of some side effects, and then on up to phase 4 trials. So we all should be fondly hope that there will be one fine morning we will find a drug that can help or cure Alzheimer's. Till such time, what is the most important thing that we need to understand is that we have to, most of the dementia patients come to us only when they are not being taken care of. What we need to identify, focus 13 to 15 years before, when they are in the preclinical Alzheimer's stage, somehow to identify and treat them before the degeneration starts. So what I feel at this particular time, we need more of memory clinics. In order to pick up possible preclinical Alzheimer, we need to establish memory clinics, at least one memory clinic in each district of Tamil Nadu. The memory clinic should assess the elders using the standard diagnostic process to assess the physical, cognitive status, and undertake relevant investigations like blood test, CT, and scan, etc. The health professionals have to counsel and provide information to help the individual sufferers and caregivers to understand the nature of illness and the treatment process. The multidisciplinary team should include psychiatrists, neurologists, geriatrician, psychologists, social workers, nurse, physiotherapist, occupational therapist, dietitian, and other related paramedical professionals. We need a team. It should be a multidisciplinary team to handle dementia. The memory clinic should give more importance and support to the caregivers due to their excessive stress and burnout due to change in the family dynamics, financial pressures added to workload of caring for the affected family member, along with other roles and responsibilities. Many of the caregivers themselves become anxious, tired, depressed, sleepless, resentful, and develop various physical and psychosomatic problems. We need to encourage the caregivers to divide the responsibility of caring with other family members, speak to a friend or volunteers from a daycare center, or to call on them, which would reduce a lot of stress. Accept help from others, such as picking up groceries or driving, medical responsibilities, and finances. Find some leisure time to relax and recharge, share emotions, not compromise on sleep, and join a supportive group. Other therapies that include are effective in managing the Alzheimer's disease persons. That includes music therapy, reminiscent therapy, meditation, art therapy, aromatherapy, reality orientation, and whatnot. So, we have to focus on prevention of Alzheimer's rather than treating Alzheimer's at the end stage. The onset of Alzheimer's disease cannot be prevented, yet the probability can be reduced by maintaining an overall healthy lifestyle. Regular physical exercise may be a beneficial strategy to lower the risk of Alzheimer's and vascular dementia. Current evidence suggests that nutrition plays a vital role in protecting from Alzheimer's disease to a great extent, like eating plenty of fruits, nuts, vegetables, and whole grain. A number of studies indicate that social connections with friends, relatives, reading books, solving puzzles, playing games, attending Tanpsycon, all give concrete support in times of need. It lowers the risk of cognitive decline because the only protection is stimulation to the brain by reading or writing or discussing and all these things. And then, in addition, moderate alcohol consumption, mind the word moderate, abstinence from smoking, use of substance use, adequate sleep, yoga, meditation, it impart good health, relieve stress, and evoke inner peace. Because peace is something, most of us go and search in search of peace. But one of my friends used to say, the happiness is within. It is extremely difficult to find it, but it is impossible to find it anywhere else. Having a villa, a Mercedes, or a Rolls Royce doesn't give you the inner happiness. So I think I always tell my students also, be happy that you have chosen this profession. We may not be earning $1 million or $1 billion, but that million hearts we can win by being nice to them. I always tell my student, go to bed with a smile and get up with a smile and then be thankful to God and all these things. Because somebody was mentioning that famous writer Sujata used to say, at the age of 65 years, if you are able to get up and go to the restroom on your own without someone else's help, you should be the most fortunate man. You should be thankful to God because there are so many elders who cannot do that thing, who need help and all these things. So to conclude, Alzheimer's disease is the most common of many causes of dementia in the elderly, and its prevalence is increasing worldwide. Probably all of us have to focus on new strategies which focus on drugs in the preclinical Alzheimer's with the help of biomarkers which can predict disease progression. It is of vital importance that more clinical trials and research should be undertaken to addressing this challenging area of Alzheimer's. Further, the family, the carers, the health professionals require more education and training in ethical decision making and conflict resolution to help people living with dementia hold on to their lives and things by love. Many of the elderly were taken care of by the multi-generational Indian families, but it is slowly disintegrating. We come across a lot of elderly people who are very happy the son has been in IIT, he got a US visa and he is in Canada or USA, but then what they have the the house can get them so many 10 crores or something like that. But they always say, Dr. Satyanathan, what we want is somebody to ask me, Appa, you are looking tired. Did you have coffee? But he sends only $3,000 or $4,000. At the age of 75, what do I do? Then I said, why don't you go for a walk and your wife is there, enjoy, you have a second honeymoon and all. No, I go for a walk, doctor. I go up to the compound wall and pick up my Hindu paper. That's the only walking I do. What about your wife? Yeah, she gets up from the bed and go to the toilet. That's the only thing and all these things. There are many elderly, whether in Annamalaipuram or Adayar or Anna Nagar, and you will see a lot of elderly people who are living alone. What they need is love and affection, attention. That is why we get innumerable calls from people to take care of elderly people. But there are no single place where they can be referred to. Because most of the time, we don't have, it's very expensive to employ day carers because they charge about 1,500 rupees per day and all. It's very expensive. Some of the children living in USA can afford, but after some time they also feel, but we do not know the quality of care these people provide and all these things. So it's very important that most of us, I think you should think in terms of starting dementia care centers, because dementia and depression in old age, they are going to be the major public health problems in the years to come. So we should be prepared. And I thank you very much. And the Indian Psychiatric Society, the President and Honorable Secretary and Honorable Members for choosing me to deliver the oration in memory of Professor ABR. Long live our this thing. I want to finish. Kindness can transform someone's dark moment with blaze of light. You will never know how much your caring matters. So care for people and make a difference for another person today. Valga Tamilagam, Jai Hind. Thank you.
And every practicing psychiatrist, young psychiatrist would have seen 2-3 cases of dementia every week, and experienced psychiatrist would have seen 10 or 15 cases of dementia every week we are seeing. And I thank Professor Dr. Satyanathan for giving an elaborate talk on dementia from early diagnosis to love and affection at the end, covering everything. And at this juncture, I would like to invite Professor Nambi to say a few words about Dr. Satyanathan. About IPS.
Of course, there is no question or thing after orations. Please sit down. Yes. Dr. Satyanathan and myself were classmates from MBBS first year, DPM and MD together. And we were a long association. But I will come here only to just a minute about IPS Tamil Nadu history. Youngsters should know. It is founded in 1985 in Coimbatore Agriculture College by one of the 5 founder members are Professor V. Ramachandran, Dr. T.N. Jayaraman of Coimbatore, Dr. Mathrubudam, Dr. Palaniyappan and myself. All the 4 dead already, and I am the only person alive. The 5th Psychiatric Conference, Tanpsycon, was organized by me in Hotel Ambassador Pallava in Chennai. That was the first 10-sitting conference, where 95% of all the Tamil Nadu psychiatrists then, it was only 200 or 250 those days. They were attending, almost all. That was a 10-sitting conference. Till then we used to have a classroom or lecture hall or somewhere. That is the time, first time we arranged in a 5-star hotel and the 10-sitting. So this I want to remember. It's nearly 37 years the IPS Tamil Nadu branch started, and it was the founder members were Dr. V. Ramachandran, initiative, and T.N. Jayaraman of Coimbatore, Mathrubudam, Chennai, and Dr. Palaniyappan and myself. This just to want to make a comment in between. Thank you very much.
Sir, now we are handing over the memento to Dr. Satyanathan, sir.
a kind announcement. PG student Dr. Deepika from JIPMER has been selected for Professor V. Balan Award, but unfortunately we don't have her presentation. So if she's around anywhere, please come over to the front desk. I repeat once again, Dr. Deepika from JIPMER. If she's anywhere around, please come over to the front desk in the main hall. We shall now break for tea and gather back in 5 minutes. Tea and snack. Please welcome back. We are moving to the next session, Professor Dr. V. Balan Award. I call upon Professor Dr. Sabita Ma'am and Dr. Babu Bala Singh sir to come over to the dais to address as chairpersons.
Good morning, everyone. I think for the Professor V. Balan Award for the postgraduates, we had actually 11 papers, and out of that, 5 had been selected for the floor presentation. So the papers are Dr. Deepika, Dr. Pooja Govind, Dr. Veera Sami, Dr. Thenmozhi, and Dr. Karthikey Selvi. I think Deepika has not come for the floor presentation, hopefully. Yes? Dr. Deepika has not come for the floor presentation. Okay, then we'll go with Dr. Pooja Govind. Yeah. Pooja Govind from Mahatma Gandhi Medical College Hospital. Yeah.
Good morning, respected all. Thank you for giving me this opportunity for presenting for the Professor Dr. V. Balan Award paper. I am Dr. Pooja Govind, final year postgraduate, Department of Psychiatry from Mahatma Gandhi Medical College and Research Institute. Presenting on association of psychiatric morbidity and dry eye disease among patients attending a tertiary care hospital. It is a cross-sectional study and it is an interdepartment study between Department of Psychiatry and Department of Ophthalmology. So basically I would like to start with telling about the dry eye disease. It is the most prevalent ophthalmological condition and it is a generic condition where it is a multifactorial cause is present. Here we see that this cause can be demographic causes like late onset, like around the age of 50 years, female genders, postmenopausal females, which have most common cause we see here. Other causes are like autoimmune causes. We also have causes like people who are more exposed to a high altitude, and all those people are more prevalent to have this dry eye disease. World prevalence is 5 to 50%, and in India it is little higher than the global prevalence, where we see it is from 18 to 50%. The chronic discomfort which is caused in this dry eye disease, it may lead to a negative impact such as in cognitive processes like executive functioning can be affected, their regular work can be affected, the mood, these people present with low mood, anxiety, and they end up having a psychiatric disorder. In a recent meta-analysis which was done, they found out that there are 22 studies where dry eye disease and was having comorbid depression, and 11 studies where the patients with dry eye disease had anxiety. So the most common symptoms which you see in dry eye disease is grittiness, visual disturbances are common, they have itching, pain, foreign body sensations which causes a lot of discomfort and dryness. So what are the common risk factors? Like in previous studies they have found out like elder age, that is older age, above the age of 50 years, female genders, postmenopausal females have most common dry eye disease, and depression is also common among them. In Indian studies, actually there is no study which is done in psychiatric population, but in ophthalm population when they have found out that the mild DID is present among 23% of psychiatry patients have mild dry eye disease. And when they have dry eye disease of moderate and severe severity, there is high risk of having a psychiatric morbidity. There is a recent study done in India where they have also told that the alcohol use also causes affect the ocular surface. Basically, then again the cause here is inflammation, because there are 3 layers of tear film, that is the lipid layer, the aqueous layer, and the mucus layer. Anything affecting these 3 layers can lead to dry eye disease. And sleep disorders are very common in dry eye disease, which is affecting half of the population. Same thing goes with anyone having a psychiatric morbidity can again have sleep disorders. So there is always a bidirectional relationship which we have. And then we see the quality of life, because the quality of life as such can cause dry eye disease, and the patients who have dry eye disease have very poor quality of life, which has been studied earlier, where it affects their physical, social, psychological and workplace productivity. So the aim was to study the association between the mental disorder and dry eye disease among patients attending a tertiary care hospital. And my main objective of the study was to estimate the prevalence of dry eye disease among patients suffering from mental disorder. We also grouped them into Group A and Group B, where Group A was the patients who had both mental disorder and dry eye disease, and the other group was only mental disorder. And we compared them based on their socio-demographic variable, clinical variables, sleep quality and quality of life. It was conducted in the outpatient department of in the tertiary care hospital in southern India. Convenient sampling method was used, and patients who all the patients coming to psychiatry OPD, one day of the week was chosen, that was Thursday, and they were all above the age of 18 years, of all genders were included. It was a cross-sectional analytical study. Sample size was 71. Consent was obtained from the patient and the LAR, and ethical clearance was obtained. So it goes like the patients who are attending the psychiatry OPD, both new case and review cases were taken. For new cases, the standard psychiatric evaluation procedure was done with confirmation of diagnosis by the consultant psychiatrist, and then we applied OSD, that is Ocular Surface Disease Index score, for the diagnosis of dry eye disease. This is the most commonly used scale for diagnosis of dry eye disease, following which we grouped them into Group A and Group B. The Group A had mental disorder with dry eye disease patient, and Group B had only mental disorder. Following which, the group A patients were referred to ophthalmo OPD, where we did tear film breakup time to know the severity level of dry eye disease which was present among the psychiatric disorder patients. Finally, we use CGI severity score for checking the severity of the mental disorder. We also checked their sleep quality and quality of life, and the statistical analysis was done using SPSS software using version 21. So inclusion criteria was same, and exclusion criteria were those who were not able to give the consent, not able to comprehend or respond to the questions which were asked, because most of them were objective tests which were done, and then agitated B patients, uncooperative for the ophthalmological test, and who were not ready for the detailed psychiatric evaluation, major neurocognitive disorders like IDD, and certain ophthalmological conditions like contact-less users, then LASIK surgeries on long-term topical eye drops, anti-glaucoma treatment for more than 6 months, and on treatment of any allergy and any recent eye surgery. These were excluded because they are prime causes to lead to dry eye disease. So the tools used were OSD, that is Ocular Surface Disease Index. It is basically most frequently used 12-item scale, and score more than 10 is considered as positive. It was validated in Tamil. Again, we use CGI scale for severity of the psychiatric illness. So this is my OSD score, validated in Tamil. And another scale which was used was quality of life, enjoyment and satisfaction questionnaire. It is basically a 96 items questionnaire, but we used the shorter form of it, which is 16 item. It is a self-report, and it measures the degree of enjoyment and satisfaction experience. Question number 16 were evaluated separately because it tells about the overall life satisfaction. This was also validated in Tamil. We also use sleep conditioning indicator, which was not previously studied in much studies, which used in much studies. It is very reliable and sensitive to change in insomnia severity. It was a 8-item scale based on the DSM criteria, and which was also validated in Tamil. So this is the sleep quality conditioning effect. Another tool which was used was tear film breakup time. Here, how do we do is we use a fluorescent strip which will stain the eye. After this, the patient is asked to blink for 3 to 4 minutes. The dye gets distributed over the conjunctival sac, and then the patient is asked to see straight without blink. When the eye is scanned over the slit lamp examination under a cobalt blue light, what happens is then the first time where the tear film ruptures, it is manifested by the appearance of a black island which is seen in the slit lamp, and then we calculate it. Normal is more than 10 seconds, and it goes with mild, moderate and severe. So coming to my results, the sample size was 86. Mean age was taken to be around 35 to 45. Females were higher among the entire sample. This is my entire sample size results, and for more of them, 47.5 were not formally employed. Education status was up to high school in 50% of sample, and most of them hailed from rural areas. On seeing the clinical variables, we saw that most of the patients had schizophrenia and other psychotic disorders. Median duration of illness was 18 years. Antipsychotics and antidepressants were most commonly used, and medical comorbidity was present among 15%, among which 8% had hypothyroidism. And the mean quality of life score was 39.27, and the sleep was nearly 5 to 28, it was ranging. Coming to the group results, we saw that in group A, out of total 86, group A had 38 members, 38 participants, that is mental health disorder with dry eye disease, and group B had only mental disorder, which were 48. And when we went for T-BERT, we saw that no one had any severe dry eye disease. We could only find that most of them had mild DED, that was 56%, and moderate was present among 44%. So on comparing, significant difference was seen only among the age, and other demographic variables like gender, marital status, education or occupation, we could not find any significant difference. Coming to the psychiatric diagnosis, we saw that patients who had both dry eye disease and mental disorder, most of them had anxiety and other stress-related disorders, following which the second diagnosis most common was depressive disorder. And in CGI score, we saw that most of them were having mild, moderate severity of the illness. The duration of illness was not significant. Medications were also not significant. However, it has been studied before that there is a significant difference. The quality of life was comparable and it was found to be poor, leading to like most of them having poor quality of life, and quality of life score also was significantly different. And the sleep conditioning indicator, we saw that it was nearly around 18 points towards the people who had both the disorders, and it was higher in who had only mental disorder. We also did a correlation for quality of life raw score and the sleep condition, and we saw there was a significant difference. So coming to the discussion, dry eye disease was present around 44%, whereas in the previous study only 23% is present. In our study we could not find any socio-demographic variable difference, but however in previous studies there has been a clinical difference present. In our disorder, anxiety and depression was the most common studies which has been studied previously. Severity of illness, we saw that in group A the severity of psychiatric illness was more compared to the others. This finding has not been present in previous literatures. In our study there was a significant impact of there was no significant impact of medication and comorbid medical diagnosis, but however previous studies show that this can be a risk factor. Sleep quality was impaired, and this above findings have been studied earlier. And the quality of life was also poor among the patients who had both the illness. The strength of my study was, our study aimed to evaluate the dry eye disease prevalence among patients attending psychiatric OPD. The evaluation of sleep was done by sleep conditioning indicator, which is based on DSM-5, which would have added better for the outcome. And our study evaluated patients with psychiatric diagnosis across the illness. The limitation of my study was the study size and the study design. And I would like to conclude by telling that the current study tries to bridge the knowledge gap regarding the relationship between dry eye disease and psychiatric disorder. Thus, dry eye disease is quite prevalent among the psychiatric disorder and has significant impact on their quality of life and sleep quality. And treatment of this dry eye disease would help us to have an overall better outcome in their life. These are my references. Thank you.
That is, in your sample, how many of them had anticholinergics? Usually you prescribe triaxiphenidil,
yes,
no?
Yes,
Any of them, because you told about the antidepressants, antipsychotics,
yes,
benzodiazepines, but how many of them had anticholinergics? Whether they had more dry eye disease compared, or it's the same?
No, ma'am. Actually, we have clubbed them into others, like those groups were others, and the others, that was only 2.6% were having, because we took like those who were only THP, we were not able to get
No, because with antipsychotics and usually you prescribe,
yes,
no,
yes,
triaxiphenidil.
Yes,
Whether those they had more dry eye disease, we wanted to know, or it doesn't have any difference, significant difference.
In our study, we were not able to get, because we have not grouped them among different and compared them. We were not able to compare that. So that is why we were.
Question from the floor. Any questions from the floor?
Sir, I call upon Dr. Babu Bala Singh over to the dais as a chairperson.
Anything you want to ask? So if there are no questions, I think, thank you.
Thank you so much.
Next speaker, we call upon Dr. Veera Sami from Chengalpet Medical College.
Good morning to one and all. I have done a study on socio-demographic profile and psychiatric morbidity among transgender. This is a community-based cross-sectional study. Coming to introduction, transgender people refers to persons whose identity and gender is different from their birth-assigned sex. Transgenders are experiencing discrimination and prejudice in all domains of their personal and social life, psychiatric comorbidities are likely to be more prevalent among transgenders who face discrimination and stigma and also the ever-growing abuse. This study was done to assess the psychiatric morbidity among transgenders and the relationship between perceived discrimination and harassment with mental health. Aim and objectives: to assess the depression, anxiety and stress among transgender people, to correlate depression, anxiety, stress with the socio-demographic profile, to correlate depression, anxiety, stress with stigma, satisfaction with life and loneliness. Methodology: the study was done among transgender living as a community near Chengalpattu. Informed consent was obtained. Institutional ethical committee approval was obtained. 50 transgender persons who gave consent were included in the study. Comprehensive interview and mental status examination was performed. Information about socio-demographic and clinical profile was collected. Depression, anxiety, stress scale, that is DAS-21 scale, was used to assess the depression, anxiety and stress among them. A score of greater than or equal to 10 for depression, 8 for anxiety and 15 for stress was taken as cutoff using DAS-21. The everyday discrimination scale, satisfaction with life scale and UCLA 3 items loneliness scale were used. Then statistical analysis was done using SPSS version 20.0. Regarding results in the socio-demographic details, 56% of them are between the age group of 18 to 30 years and 96% of them were male at birth and 44% of them from a rural area and 48% of them belonging to the middle socio-economic status and 54% of them had secondary school education and 56% of them had baking as a primary source of income and 66% of them staying in rented house and 68% of them staying with their transgender colleagues and 70% of them recognized as transgenders within 20 years of age and 74% of them left their house within 20 years of age. 56% of them involved in sex work. In that 48% of them done gender reassignment surgery and in them 28% of them done it legally and 24% of them had physical comorbidity. In them 12% of them got treatment from private hospitals and 52% of them registered in their association and 30% of them had history of suicidal attempts in the past and also 62% of them had substance use as a history and 58% of them expecting housing, employment and health facilities. Regarding psychiatric morbidity among transgenders, according to DAS-21 scale assessment, about 34% of them had depression, that is about 17 of them, and 18% of them had anxiety, that is 9 of them, and 26% of them had stress, that is about 13 of them. And regarding discrimination, dissatisfaction with life and loneliness among transgenders, with all 10% of them facing discrimination and 42% of them dissatisfied with their life, that is about 21 of them, and 26% of them feels lonely, that is about 13 of them. Then we also found that transgenders living in a rented house had a statistically significant stress with a p-value of about 0.05 and transgenders involved in sex work are dissatisfied with their life, which is statistically significant. That is also, that's p-value is 0.01. Regarding the correlation between depression, anxiety, stress with discrimination, dissatisfaction with life and loneliness, the transgenders who feels lonely and dissatisfied with their life had statistically significant depression and stress. These are the respective p-values like 0.001 and 0.002 and 0.003. Transgenders who feels lonely had statistically significant anxiety with a p-value of 0.001. Discussion. In our study, depression was seen in 34% and anxiety was seen in 18%. This finding is similar to the study done by Niranjan Hebar OR et al. At 2016 in transgender people from Manipur. In that, depression was seen in 46.87% and generalized anxiety disorder was seen in 37.5%. In our study, depression was seen in 34% and anxiety was seen in 18% and stress was seen in 26%. This finding is higher than the finding of the study done by Farnas Farman et al. 2019 in Iranian transgender women reported that 22% of them had depression, 20.4% of them had anxiety symptoms, and 17.3% of them had stress. This is because we consider all the severity from mild to extremely severe. Our study shows that transgenders who involved in sex work were dissatisfied with their life, and also the transgenders who dissatisfied with their life were depressed. This finding is similar to the finding of the study done by Ruji Chang et al. 2019 in the Chinese transgender woman who was involved in sex work. Reported that 25.25% of them had severe depression. And also, our study shows that 42% of the transgenders were dissatisfied with their life, and 26% of them feels lonely. This finding is slightly lower than the findings of the study done by the Norman Anderson et al. 2022, reported that 64% of them of non-binary transgender individuals were dissatisfied with their lives, and 38 to 52% of them feeling left out or lacking companionship either often or very often. This is because the transgender population of our study lived as a group in a community. Conclusion: the study concludes that prevalence of psychiatric morbidity among transgender were more who are facing discrimination, dissatisfaction with life, who feels lonely. Proper attention should be given for the socio-economic requirements and living conditions that would improve their quality of life. We are doing a follow-up with the transgender community in order to address their requirements. We have employed six of them in Chengalpattu Medical College Hospital as a housekeeping staff for last 2 months. We have represented their issue to the district collector for further action. We hope these steps would enhance their quality of life. Thank you, sir. These are my references.
Any questions from the floor?
The scale you have used, is there any significance to use that scale?
Thank you for your question, sir. The DAS scale is one validated scale, and it is available in 23 languages, and it is a self-reporting scale and easy to administer. Because of the self-administration scale, they can report it very easily. That's why we used, sir.
Any questions from the floor? Yes.
The study, hello. The study you have presented now is very interesting and enlightening as well. And the way you have delivered those data are also quite impressive and
You're
catchy.
not supposed to comment on this since it's
Okay.
big in award paper. Any
All right.
questions that can be asked?
Okay. How do you distinguish the cause for the loneliness and also the high incidence of depression among the transgender? How do you distinguish whether it is due to them being as transgender and because of the socio-economic situation they are pushed into?
Thank you for your question, sir. By our study, we came to know that all the transgenders, about 50 transgenders we interviewed, all of them are getting the experience of discriminations that in every domains, and also we also seen that transgenders who are living with their colleagues and also living alone, and the transgenders who are living with the colleagues and friends, they are showing less number of depressive symptoms and anxiety symptoms, comparing to the transgenders who are living alone, and also who are living in a rent house, and because of that financial issues and loneliness, the depressive symptoms and anxiety symptoms are, and stress also high in that domains. That's.
Okay. There are no questions, I think.
You told there is a similar finding in one of your discussions. but the prevalence of anxiety was twice in the other study.
Yes, sir.
And you made a comment, the findings were similar.
It's a little bit less, sir, actually.
It was, if you go back to the slides, I will show. The other comparison with the previous one, previous one.
This one?
Yeah, anxiety is 18%. The other study, it is 37.5.
Yes, sir. Sir, because the transgenders we studied are living as a group in a community. That's why the findings are reduced in our findings, sir.
Yeah, okay. The other thing is you are compared, yours is a similar, predominantly male population. And you are compared with the Iranian study, which had a predominantly female population.
Yes.
Can they be comparable?
Next slide. Person study was transgender woman.
Converted men to women. That's what. It's transgender women is
Women.
men to women, the same
Yes,
population.
same population. Okay.
I think if there are no questions, we'll wind up.
Thank you.
Thank you. Right. The next presenter will be Dr. Tenmozhi from PIMS Puducherry.
Good morning, all. Good morning, all. Today I am going to present my study, Alcohol Dependence Syndrome, 6-month course and outcome. Investigators are Dr. Tenmozhi, Susan Solomon, Dr. Pathasarathi Ramurthy, Dr. Pradeep Tiragan, Department of Psychiatry, Pondicherry Institute of Medical Science, Puducherry. Introduction. Globally is the third largest risk factor for disease and disability is the consumption of alcohol. Alcohol dependence constitutes an important public health problem worldwide because of its recurrent and persistent cause. According to WHO, in 2016, alcohol use disorder present in 4.9% and alcohol dependence prevalent in 3.8% of Indian population. And alcohol dependence has a deterioration of physical and mental health and also lead to detrimental effect on an individual family, occupation and social life. And several effective treatments are available for alcohol dependence syndrome, and treatment frequently fail due to the various factors which ultimately result in poor outcome. Only a few studies have addressed the cause of and outcome of patients with alcohol dependence. The objective of my study is to determine the 6-month course and outcome in individuals with alcohol dependence syndrome and to determine the socio-demographic and clinical correlate of outcome in these patients. And materials and method. It is a longitudinal observational study and inclusion criteria include age more than 18 years, male gender, and who fulfill the ICD-10 criteria for alcohol dependence syndrome. Exclusion criteria include patient with alcohol dependence syndrome with comorbid major psychiatric disorder or intellectual disability. And approval is obtained from the Institutional Ethical Committee and approval number is IEC RC/2020/114. A written informed consent was obtained from the participant. And at baseline, socio-demographic data such as age, education, occupation, marital status, socio-economic status, and contact details were obtained. And clinical data such as age at onset of alcohol dependence, duration of alcohol dependence were collected according to pro forma. And treatment as usual was provided on inpatient or outpatient basis. The patient underwent subsequent assessment at 2 weeks, 1 month, 3 months and 6 months. At each follow-up assessment, the following details were obtained: complete abstinence and proportion of day abstinence, proportion of heavy drinking days. and patient did not come for the assessment at the expected time, the patient and or the family members were contacted over the phone with a request to review in the psychiatry outpatient department. And the patient and or the family members expressed an inability to review in the OPD. Relevant details were collected over the phone. If the details given by the patient and the family members did not concur, the worst of the two was considered. Sample size. We anticipated that 30% of the patient will be abstinent in 6 months based on the previous study, and sample size was calculated using this formula 4pq bar d square. For an accepted deviation of 10%, the sample size required was 84. Assuming a dropout rate of 10%, we aim to include 93 patients in this study. Statistical analysis. Categorical variable were summarized as frequency and percentage, where mean and standard deviation was computed for or continuous variable. Proportion of patient abstinent at each follow-up assessment was calculated. Mean number of day abstinent and heavy drinking days were calculated for those patients who were not abstinent in 6 months. And univariate logistic regression was conducted with abstinent and 6 months as outcome variable and selected variables from previous studies as independent variable. Multivariate logistic regression was conducted for those variables in which p is less than 0.10 was obtained on univariate analysis, and p-value less than 0.05 was considered statistically significant. Result. In our study, we have recruited 94 patients. In this, mean age of the participant is 43.98 years, and the more than 3/4 of the participants were Hindus, and majority of the participants were married. 1/3 of the participants had completed high school, and middle school and the primary school together constituted about 1/3 of the participants. And the semi-skilled worker followed by unskilled worker together constituted about half of the participants. Nearly 3/4 of the participants were from middle socioeconomic status, and more than half of the participants had family history of alcohol dependence. This is table 1A, shows the clinical detail of the study participant. In that, age and onset of alcohol dependence mean is 35.90 in years, and the mean duration of alcohol dependence is 7.60 in years. Average alcohol consumption in last month is 16.37 in units. This is a table column which shows the patient motivation at the time of recruitment. The patient at the time of recruitment is pre-contemplation stage is 54 and contemplation is 30. We have recruited 94 patients. In this, 92 patients completed 6-month follow-up, but the 2 patients lost follow-up and the 4 died at the end of 6 months. This is a figure which shows the proportion of patients abstinent at each follow-up. In this 2 weeks, 80.43% of patients were abstinent, and 64.13% were abstinent at the end of 1 month, and the 41.03% were abstinent at the end of 3 months. The result of our study is the 29.34% abstinent at the end of 6 months. Among those who were not abstinent at 6 months, the mean number of abstinent days was 113 days, and the mean number of heavy drinking days was 56 days. And this is univariate logistic regression. In which the age of the patient, locus of treatment, and motivation at recruitment were associated with the abstinence status at the 6 months, or the age and onset of alcohol dependence, duration of alcohol dependence, past detoxification or de-addiction treatment, and nicotine dependence were not associated with the abstinence at 6 months. However, on multivariate logistic regression, none of the above factors were associated with abstinence status at 6 months. This is table 2A, which shows the univariate analysis to predict the abstinence in 6 months. In this age, locus of treatment and the motivation at recruitment were associated with abstinence in 6 months. This is a table 2A. This is a multivariate analysis to predict the abstinence in 6 months, in which none of the factors were associated with abstinence in 6 months. Discussion. In our studies, more than 1/4 of the patients were abstinent at the end of 6 months. Similar findings were also obtained by an Indian study, where the author found out that at end of 6 months, 27.5% of the patients were abstinent. In another study from India, Sarkar et al. Observed that the proportion of patients abstinent at the end of 2 years and above was 31.35%. Similar results were obtained by Abraham et al., who found that 32.5% of patients with alcohol dependence syndrome were abstinent at the end of 1 year. Carr et al. Conducted 1-year longitudinal study and found out that 46.7 patients were abstinent. Different abstinent rate were reported in studies conducted in different parts of the world. Gual et al. Conducted a 20-year longitudinal prospective study in Spain and found out that 32.6% patients were abstinent. Terra et al. Conducted a 6-month follow-up study and found out that 24.1 patients were abstinent. And Soyak et al. Found out that 58% were abstinent at the end of 2 years. Different in outcome can be attributed to different in study population, method of assessment, variation in the length of follow-up, and socio-cultural difference. Strength of our study is a low dropout rate and predefined outcome criteria. But the limitation of our study is telephonic follow-up assessment in the significant proportion of patients. Since this is a single center study in the tertiary care teaching hospital, the generalizability of the study finding may be limited to other settings. And conclusion, more than 1/4 of the treatment-seeking patients with alcohol dependence syndrome remain abstinent at the end of 6 months. The factors associated with abstinence in 6 months were age, locus of treatment, and motivation at recruitment. This is the reference. Thank you.
Well, one thing, what do you mean by the locus of treatment?
It is whether it is an inpatient or outpatient treatment.
Well, how many of them had inpatients and how many were outpatients? Because you didn't mention about
Yes,
that,
ma'am.
right? That's what?
Inpatient is 40 and outpatient is remaining.
31.
Yes, ma'am.
So 93 of
93,
was
ma'am.
the sample, right?
Yes, ma'am.
So half of them were inpatients.
Yes, ma'am.
So the inpatients, where they are treated as inpatients, that is the 6-month abstinent rate was good. That's what.
Yes, ma'am.
Then you should have put that, no?
Okay.
Locus of treatment, either because what is that you should have mentioned. What is the IP or OP? If the IP treatment had been better. IP every time? How many times in that 6 months? Any idea? It's only one time.
Yes, ma'am.
Only one time IP treatment. Yes. Any questions from the floor?
Dr. Tenmuli? See, what was the hypothesis of the study?
There is no hypothesis in this.
No, what do you want to really find from this?
At each follow-up, how many % of the patient was abstinent?
That means you have to do locus of control, not locus of treatment.
Okay.
You have an external and internal locus of control. We all know that external locus of control is higher in alcohol. It is the patient attenders who bring the patient for the treatment. Okay. So your study is just lame like alcohol dependence syndrome. You should have pinpointed something, highlighted something, whether the follow-up study of abstinent or locus of control or the treatment modality or the motivational. Any one of these sub things would be there. Okay. So that would have been a better study.
Okay.
How many of the patients are contacted through telephone?
At the end of 6 months, mostly 60 to 70 patients was contacted over the phone, sir.
Okay. So in that case, how you have ascertained whether they were really abstinent, the number of days they were drinking?
Patient, first we contacted family members, sir. We collected the data and then we called the patient. We collected in this which verse was taken as a data, sir.
No. What I'm saying, it is not a point like patient is using alcohol or not. You have mentioned the number of days.
Yes, sir. We called him and we asked him the details from the family members. From the last visit, how many days he was abstinent and how many days he was started drinking. And also some of the patient came for follow-up in between during the 3 months.
So how reliable would be your findings?
Yes.
Because we know all patients using alcohol, they usually frequently minimize the dose. The drinking, they frequently lie there about their alcohol use, or they hide. So all the things are there, no?
Yes, sir.
Excuse me. Did you give any kind of intervention at the time of telephone contact with the patients?
Yes, sir. We called a patient and come for further treatment to our hospital.
So you kind of enhance their motivations to attend and
Yes,
be
sir.
abstinent.
Yes, sir.
Will that be considered as one of the important interventions for them being an abstinent for a long period?
Yes, sir.
Because in our hospital, we have a database of who have had a recent treatment, and then for following their discharge, we regularly follow them with telephones. We believe that kind of interventions motivate them to be abstinent for a longer period of time. Did you consider that as a kind of interventions as a factor, one of the factor for long-term abstinence for your study?
Yes, sir. We call the patient during the time they, due to that, if they relapse also, they came for the treatment and remain abstinent after that.
So, can this be generalized in a kind of general treatment of the people receive in the community? For example, those who get treatment get discharged and they never get followed up through the telephone.
Yes, sir.
And because of their motivation only, some of them are turning up into the hospital for further counseling.
Yes, sir.
Your kind of interventions like a telephone follow-up, can this be generalized as a mode of interventions for people treatment?
Yes, sir. We call the phone so that they came back and they underwent treatment after that.
Any other questions, sir? Dr. Srinivasan, sir? Right. If there are no questions, thank you.
Thank you.
We call upon Dr. Karthikey Selvi from PSD Institute of Medical Sciences and Research, Coimbatore.
Good morning, one and all. Here I am to present my feasibility study on brief psychosocial interventions through mobile phone for patients who are admitted following a suicidal attempt. Suicide is a major public health problem. Worldwide, approximately there have been 800,000 suicides per year. The estimated suicide-related death rate in India is 21 per 100,000, which is twice the global average of 11.4 per 100,000. The risk of further suicide is high in an individual who had undergone adequate life-saving medical management but without addressing the mental crisis. A survey was done in PSG hospital in which patients who were admitted in the medicine department following suicidal attempt underwent psychiatric assessment, and after discharge, 80% of them did not even come for one follow-up visit. In this background, the aim was to study the feasibility and acceptability of mobile phone-based psychosocial intervention and face-to-face intervention in patients who are admitted following a suicide attempt. All patients who get admitted in the Department of Medicine following suicide attempt are routinely referred to psychiatric department for complete psychiatric evaluation. After evaluation, once when they are physically stable, patients are enrolled to participate in the study. We included the patient who could speak either Tamil or English, who were aged between 18 and 65 and who were having an access to mobile phone. We excluded the patients with intellectual disability, cognitive impairment or active psychotic symptoms. Before discharge, patients were given two options for follow-up treatment: to choose either mobile phone-based psychosocial intervention or face-to-face psychosocial intervention. The interventions were structured as 6 sessions in total, 1 session per week, and duration of each session being 20 to 30 minutes. Each session started with probing and ventilation of psychosocial problem, assessing the depressed mood and suicidal risk, and teaching them problem-solving skills and mindfulness. Each session ended with providing contact information for psychological support at the time of crisis or increased suicidal ideas. Based on their choice, WhatsApp video call were made for mobile phone-based intervention and OPD visits were suggested for face-to-face intervention. Reminder messages were sent 1 day prior to the scheduled appointment. If the patient did not attend the scheduled appointment, at least 2 phone calls were made to know the reason, and appointment was rescheduled if they wished. If there were no response to 2 phone calls, it was concluded that the patient had dropped out. All psychosocial interventions were delivered by me under the training and supervision of clinical psychologists. At baseline, a structured proforma was used to collect socio-demographic and clinical detail. Columbia Suicide Severity Rating Scale was used to assess the suicidal risk. Beck Suicide Intent Scale was used to assess the suicidal intent. Tamil version of Beck Depressive Inventory was used to assess the level of depressive symptoms. At the end of 2nd and 6th session, suicidal risk and level of depressive symptoms were reassessed. Also, at the end of 2nd and 6th session, the likability of intervention was assessed using a visual analog scale where scores ranged from 0 to 10, 0 that patients were not at all satisfied and 10 that they were extremely satisfied with the intervention. Coming to the results, between 27 November 2021 and 10 June 2022, 34 patients were assessed, of which 16 patients were excluded for the following reasons. 18 patients were included. 17 among them chose mobile phone based psychosocial intervention, while only one opted for face-to-face intervention. The mean age of the study group was 31.61 years. Most of them were female and most of them were married. All of them were educated with a minimum of high school degree and majority of them were from the upper middle and lower middle socioeconomic status. About 27.8% of them had past history of suicidal attempt and half of them had comorbid physical illness and 2 among them reported that to be the reason for their attempt. Looking into the clinical characteristics of current suicidal attempt, in 2 patients, details could not be obtained as one had amnesia for attempt and one refused to give the details. In 50%, they had active suicidal ideation before the attempt. However, they had such thoughts less than once a week only. About 72.2% of them did not attempt to control thoughts and 72.2% of them had severe lethal attempt that needed hospitalization with intensive care. By Beck Suicide Intent Scale, 50% of them had low suicidal intent. Majority of them attempted suicide at home by consuming poison, overdosing medication, cutting wrist or hanging. According to these patients, family conflicts, physical health issue, marital unhappiness, stress that they did not get the wanted, death of a loved one were the reasons. By self-administered Beck Depression Inventory, 44.4% of them did not have depressive symptoms at baseline. Coming to the diagnosis, 27.8% of them had depressive episode and another 27.8% of them had marital discard. The mean duration of hospital stay was 4 to 5 days. Looking at the intervention, only one person opted for face-to-face intervention and she came to hospital only for 1 session. The remaining 94.4% of them opted mobile phone-based intervention. Looking into the mobile phone group, in total, about 52.94% of them attended at least 1 session and among them, 11.8% of them completed all 6 sessions. Comparing the follow-up rate, 20% of them only attended at least 1 session in the previous survey that was done, while 52.9% of them attended at least 1 session through their mobile phone, which was also found to be statistically significant with Fisher's exact value of p equal to 0.27. Comparing the level of depression, the mean score of Beck Depressive Inventory at baseline was 14.33 and was 15.75 at the end of 2nd week. About 3 patients had suicidal ideation at the end of 2nd week. 2 reported wish to be dead, while 1 reported non-specific active suicidal thought. These thoughts were less than once a week and were fleeting for few seconds or minutes. They were able to control thoughts with some difficulty and none of them indulged in any suicidal behavior. The mean score of likability scale was 8.50 out of 10 at the end of 2nd week. To discuss, all patients who were admitted following suicidal attempt owned a mobile phone which could be utilized for psychosocial intervention. Among the 18 patients who were recruited, 17 patients opted for mobile phone intervention and only 1 opted to come for face-to-face intervention. Treatment through mobile phone seemed to be acceptable to a patient as a self-rated mean score of likability was 8.50 out of 10 at the end of 2nd week. Suicide reattempt rates are highest in the first week and remains higher for the first 3 months post-discharge, and the enhanced risk may last for 1 to 3 years from the present attempt. Only 20% who were treated for suicidal attempt attended outpatient follow-up consultation. In the same setting, we have now found that 52.94% of suicide attempters had taken at least one session of psychosocial intervention when they are delivered through their mobile phone. It has been noted repeatedly that persons who attempt suicide voluntarily do not always seek help from the mental health services. Reason being perceived lack of need for mental health care, fear of hospitalization, financial difficulties and stigma. Early engagement with psychosocial intervention could reduce the rate of suicidal behavior. Regular telephone contacts functioned as reminders to seek help from the mental health issues. Patients felt even simple telephone calls as gestures of caring. However, in these mentioned studies, no attempt was made to deliver any form of psychosocial intervention. Indian researchers have found high rate of psychosocial stressor associated with suicide. Hence, every possible attempt should be made to deliver appropriate psychosocial intervention. Limitations of study is that it's an observational study and only a randomized control study can give the true efficacy of mobile phone based psychosocial intervention. Sample size and duration of follow-up is small and we still had dropouts. To conclude, our study proves that it is feasible to do a double-blind randomized control trial in mobile phone based psychosocial intervention. If that is proved to be positive, it can be used in the day-to-day practice. Thank you.
You told that how many of them have completed it 6 sessions?
Yes, ma'am.
Who completed? That is the patient who had depression, you told, right? Some patients who had depression. Some patients had repeated suicidal attempts. 5 of them had, when you had recruited that patients, whether they completed, who completed that 6 sessions? At least one completed, you told 50% of them completed. Who completed all the 6 sessions? Anything? Any information?
Those patients who completed 6 sessions had, one had borderline personality traits and one had depressive episode as the diagnosis, ma'am. One had past history of suicidal attempt, other didn't have, and these were the characteristics of those sample who completed all the 6. Yes, ma'am.
I have a question. So you had a slide which showed the number of participants who completed. Can you please go back to that session? Right, so my question is, I think about 50% didn't attend any sessions, right? 0 sessions, around 47%. So since this is a feasibility study, did you look at, compare the 2 groups, as in those who attended sessions and those who didn't attend any session, to see if there was any difference between the 2 groups? Because what I'm wondering is, even though most of the patients seem to have a mobile phone, they weren't and consented for the study, they didn't attend the sessions. So why was that? Because if that is something you can address moving ahead.
Yes, ma'am. Actually, that is why we were actually trying to look into the reason why they were not attending the session. Those who consent to participate in the mobile phone intervention were only included. And even after they consented, when we call back, even after giving them reminder messages, they were not able to stick up with their scheduled appointment. When we looked into the reason, they reported, few reported like they had ongoing psychosocial issues, like few had, one with marital discord, had an ongoing issue in the court of law. So she told that she didn't have time. Few reported that they were, after the attempt, the crisis was solved by the family. So they did not want to attend anymore. So these were the reasons that they reported that they didn't want to attend the session further.
Thanks. No, my question was actually, did you compare the socio-demographic data, the diagnosis and so on, to see what was the difference between those who attended and those who didn't attend?
We have not done that, ma'am.
Any reason to exclude patients with above age 65, below 18? And the corollary question is actually, did you take the phone number or mobile number of significant others? If not, so why?
While getting consent, it was both from the patient and the primary caretaker.
Because if you see the slide, I think
Yes, sir.
around 10 patients would have been recruited more patients. 10 more patients could have been recruited. The age criteria has been relaxed. Any specific reason for that, doctor?
What we felt is those who were above 18 could consent to participate in the study, sir, as an adult. So we tried to get it from those.
And what
who
about
were
65 years? They can also give consent.
Because we felt like they might have cognitive impairment or.
No, not like that. Then you don't tell 65 years are not cognitive. Many of our senior psychiatrists are more than 65 years. Okay, and they are cognitively very well equipped. So I don't think that's not a good reason to say. And also, did you take mobile number of significant others? Not only the patients.
Mostly it was obtained only from the patients, sir. For those who reported that they didn't have video call facilities, for them I collected from the son or daughter who were recommended.
Many times it is prudent to have mobile number of significant others, either parents or relatives, spouse and all, because you are telling that you are many times the main reason for is marital discord, relationship problem, family conflict, all these things.
Yes.
So which should be addressed by talking with the other people also, not by the patients.
Yes.
Many times the psychosocial stressor is involved. Okay, that should be addressed. Okay, and one more question. Did any patient or attender who attend the phone number, did they felt bad about your call? Because many times what we observe, especially there was a study going in Pondicherry, where the patients who attempted suicide, they don't want to go back the memories because your call is revoking the memories. That kind of anything has happened, event?
Even like when I had such experience with one patient, sir. When I was about to get consent for the study itself, they had a thing that if the thought should be left in the hospital and they should not carry it over to the home.
Again, right.
Parents were also supporting that and they did not consent to get into the studies.
Okay, go okay, doctor.
Thank you.
Yeah, I think if there are no questions, we'll wind up the Professor Dr. Balan Award for the postgraduates. Thank you.
We now move on to our next session, Dr. Professor M. Peter Fernandez Award, which will be continued by the same chairpersons. Thank you.
So for the Dr. Peter Fernandez Award, we had 7 entries and out of them 4 had been selected for the floor presentation. I think this time we'll have to congratulate the Chettinad Hospital, where there had been, I think, all the 2 faculties and as well as all the 4 postgraduates had presented or they had sent the papers for the award. So that I think we'll have to encourage, and other institutions also will take it up as one encouragement, and they'll do it. So for the floor presentation, first Dr. Kailash from Chettinad Medical College Hospital, Chennai.
Respected teachers, seniors and colleagues, I'm Dr. Kailash, professor from Chettinad Medical College. I'm here to present a paper on the randomized controlled study of effect of combination of exercise with SSRIs in treatment of depression in an outpatient setting. As we know, major depressive disorder is a major cause of disability and disability adjusted life years, and by affecting many domains, it causes poor quality of life. With pharmacological treatment and SSRIs being one line of management, psychotherapy with psychosocial management and lifestyle modifications are used hand in hand with that. Both these methods have significant limitations. Antidepressants have a limited clinical response rate of around 60%. Psychotherapy in India is limited by many practical constraints like availability, affordability, and expertise. We know that the best response is there when we give a combination therapy of both. Physical activity and exercise has a bidirectional effect on the relationship with depression. Physical activity or exercise increases the neurotransmitters like serotonin, endorphins, endocannabinoids, BDNF, and it also helps by decreasing the oxidative stress and inflammation, thereby helping in the neurogenesis. There are also several psychological mechanisms by which exercise helps depression by increasing the self-esteem and sexual functioning. There is huge body of evidence already that several meta-analyses are also there that exercise is a good intervention, especially the aerobic activities, for improving the depression. And exercise has also shown that there is similar level of adherence as compared to SSRI therapies. But most of the exercise intervention studies are done in inpatient settings. Supervised exercise interventions are done which requires additional personnel and infrastructure and objective instruments to measure the effect of exercise. In Indian context, there are very few studies that too have studied the preventive effect of exercise in preventing depression. There are no such studies in evaluating the therapeutic benefit of exercise. The objectives of the study was to study the outcome of combination treatment of exercise and SSRIs and to study the outcome of SSRI monotherapy and to compare both these treatment outcomes. The study design was a randomized controlled single-blinded study in the psychiatric outpatient facility for a period of 6 months and was started after ethical committee clearance. After considering for power of the study and dropouts, a sample size of 80, 40 in each groups were included. Simple random sampling using random numbered tables were used as the sampling method. Inclusion and exclusion criteria: adult patients of moderate depression, MDD, who were planned to be treated on an OPD basis were considered eligible for the study. Patients who were having active suicidal ideation and recent attempts at suicide, comorbid psychiatric illness, comorbid medical illness which is a contraindication for physical exertion, and history of regular physical exercise during the illness period were excluded from the study. So this is the flow chart of the study procedure. Patients who were consenting for the study, they were randomized by simple random sampling and they were allocated into group with only SSRIs and SSRI with exercise. The person who assesses the HAM-D and quality of life scale was blinded and the assessment happened in the baseline, 2nd week, 4th and the 6th week. In the SSRI only group, 10 patients didn't complete the study, 4 of them did not follow up and 6 of them was not adherent to treatment. 6 patients from the combination treatment did not complete the study as 3 did not follow up and were not adherent to the treatment. Finally, 30 from the SSRI group and 34 from the combined group were taken up for analysis. The exercise we instructed was based on recommendation by Dunn et al. And European Psychiatric Association, where patients were instructed to walk for 30 minutes 3 times per week at an intensity they found pleasurable or relaxing, and they were encouraged to increase it if they were found comfortable. They were assessed at 0, 2, 4 and 6 weeks. The information was also corroborated from the family members and the patients were also advised to maintain an exercise daily. The following statistical analysis was used for results. As we see in the results, the SSRI group and the combination group, the age was around 36 in both the groups and mainly females were more compared to the males, and both the groups didn't differ on the basis of age, sex, education, occupation, background, socioeconomic status, family type and marital status. There was no difference between both the groups. In the SSRI and with exercise, the duration of illness was around 5 to 6 months. The family history of depression didn't differ. When we checked on the BMI, as we see here, the baseline, from the baseline at the end of 6 weeks, the SSRI group had mild weight increase, whereas with exercise there was slight weight reduction, though this difference was not significant. The mean equivalent dose of SSRIs was converted into equivalent dose of fluoxetine, and it was around 22 to 23 in both the groups, and they didn't differ. So coming to the outcome variables, adherence was one outcome variable. Though the adherence was better in the combination group, there was no statistical difference. And the other outcome variables, if we see the HAM-D score in both the groups, they didn't differ in the baseline, but there was significant improvement in both the groups, and this difference didn't differ between the both SSRI and the exercise group. When we checked on the 4 domains of quality of life, apart from the psychological quality of life, in which there was a significant improvement which is better in the combination group of SSRI with exercise, all other quality of life measures were same in both the groups. Similar thing was expressed as a difference in the HAM-D scores from 0 week to 6 weeks. The quality of life, psychological quality of life, had significantly better improvement in the combination group compared to the SSRI only group, and the correlation coefficient was moderate in the combination group. When exercise was added, it had a moderate correlation with improvement in the psychological quality of life. So both the treatment groups showed significant improvement in depression, but there was no additive effect in adding SSRI, adding exercise to SSRI in the objective depression scores, that is the HAM-D scores. This is unlike few other studies which showed rapid and better improvement when exercise was combined with medications. This could possibly be because of the patients we included, the intensity of exercise we had suggested, and the supervision which was given. The patients in the combination group but actually felt psychologically better compared to the other group. Even though both the groups were followed up periodically, more patients tended to adhere to the combination treatment compared to SSRIs. We need to follow up this further for checking how this works out in the long run. NICE guideline actually recommends physical exercise as a treatment for mild to moderate depression. So we could given a little additional time to instruct and follow up on this simple aerobic exercise prescription, which would improve adherence and acceptability. The limitations of the study being the type and mode of administration of exercise which was chosen for intervention itself, that it was not structured, it was not supervised, but our aim was we could have made the exercise more nuanced by adding more details. We wanted to keep it in such a way that it could be easily administered by clinicians in primary care settings with no additional services. There was no objective assessment of intensity and duration, and there's always a possibility of recall bias. While blinding of assessors could be done, selection bias could still have occurred during the initial assessment of eligibility. The patient's own bias towards experience of exercise could have affected their participation in the study. And there is also a low sample size. We could have used higher sample size. The other strength of the study was that it was randomized and single-blinded. In the future, we can use the whole follow-up for longer duration for larger sample size to check whether this exercise addition helps in improving the adherence and preventing the relapse, and in different subgroups of depression. So in the conclusion, I would want to say that in clinical settings, simple home-based exercises in combination with SSRI treatment have had no additional benefit in improving the depressive symptoms, but could improve the psychological outlook or the quality of life of the patients and the attitude towards the treatment. These are my references. Thank you.
Doctor, how did you standardize your exercises?
Yes, sir.
Ensured that all the patients received the same type of exercise in your case?
Yes. Sir,
have you verified?
Have I verified? Can you complete the question?
How did you standardize? Just I want to...
Yes, sir. I mean, the instruction which was given was you can walk for 30 minutes for in 3 times a week. Walking was the prescription which was given, and at an intensity and duration, and it was also corroborated with the family member, and also checked with the exercise diary. This was possible, this much was supervision or standardization was possible in an OPD setting. Otherwise, we would have needed an inpatient setting and a supervision to have further monitoring.
Use of some electronic gadgets,
yes,
like smartphone or Fitbit.
Yes, but all patients didn't have it, and
okay.
If we had used it as a modality, then that would have excluded a lot of patients. So we didn't use that, sir.
So drug-induced well-being itself is a very beautiful concept with the use of antidepressants. So is it true that exercise has benefited really well with the SSRIs? Or do you have used any different scale for assessing the SSRI-induced well-being or something like that? Because that excludes your findings which you have mentioned here.
Okay, and my other comparison group was only SSRIs.
No, any scales you have used?
For?
SSRI induced well-being.
Yeah, I have mentioned WHO quality of life breath scale.
But you don't have any subset for that in WHO quality of life.
We had the other 4 domains. With extension of your question, there is an article in Lancet which now says that, it had a lot of controversy that even though they had taken antidepressants for a long time, their quality of life and well-being didn't improve much. That was a contention with many people. So this addition of exercise with SSRI can improve. As you mentioned, sir, I didn't check for any separate scale for well-being of the patients.
And also, this is the first episode patient or recurrent depressive episodes, or you haven't mentioned anything in your
No, I included only major depressive disorder first episode.
First episode.
No, I didn't take the recurrent depressive disorder patients.
Thank you.
Thank you. Yes, ma'am. Yes, ma'am. Yes. Sir had asked specifically about well-being of the patient. Another, did I use any scale? So that I didn't use. But in quality of life breath itself, out of the 4 domains, one is psychological quality of life, with physical, environment, and social being the other 3 domains.
Excuse me.
Yes, sir.
All those persons who included in the study,
yes, sir.
Whether they already had exercise,
I had mentioned
habit of exercise, something like
that. I had already mentioned that in the exclusion criteria, who were already doing exercise, or during the illness period also, if they were doing the exercise, we had excluded those patients. Because it would not be possible for us to compare them and randomize them and study.
So depressive episode means, did you consider the severity also? Mild, moderate, severe?
We included only patients with moderate depression.
Not mild?
No, not mild.
Okay.
We included patients only with moderate depression.
That's according to ICD-10.
Yes, ICD-10. Our average HAM-D scores was around 18 in both the groups. And it didn't differ between both the groups.
Okay. So in your study, you were saying this exercise is not significantly affecting the depressive scores.
Yes.
In your literature research,
yes, sir.
have you found any studies which they have done structured or exercise like that? The exercise is helping like that?
Yes, sir. There are many studies. Actually, they have done very, intensity of the exercise. They measure by kilocalories per hour. They have specific instruments for it. They use cycling as the method. So all these things are done in inpatient setting. As the intensity of the exercise increases, the benefit from the exercise also increases, has been there from many studies. But many of those things are done in inpatient settings, and they have found that the rapidity of response and the extent of response is also more in many other studies. So this study, we couldn't find an improvement in the depression scores. So many of the other things, like we did it only in an outpatient setting. There is also an option that we can do it for 5 weeks, 5 times in a week. And the intensity could have also been asked to increase. So maybe if we are trying those sort of exercise interventions and comparing with this, we can find, maybe hopeful that it can give better results.
Last question.
Yes, sir.
Comorbid depression, substance use excluded?
Excluded. We have excluded substance use, any other psychiatric illnesses.
Yeah.
Yes, sir. No, sir. Only walking, sir, because we had asked patients to do it in the home-based outpatient setting, which we can, yes, sir. No, sir. There are mind-body exercises like yoga, tai chi. So we didn't do anything of that. We only asked them to do motor exercise, walking for 30 minutes. And we monitored on that. So our idea was to check in home-based clinical setting itself, are we able to bring about a difference by adding this small intervention? Yes.
One more question.
In my view, it's a quite a challenging study because we cannot control the control groups, especially regarding the exercises. How did you manage to control the controls? For example,
yes,
if you repeatedly ask in the outpatient follow-ups whether you do exercises on those who do not do exercises, then they become conscious about the need of exercise, yes, because the doctor is asking such a questions.
Yes.
And they end up going and do some sort of exercise. How do you kind of manage to do controls?
Thank you, sir. Thanks for that question. We thought that there might be a situation in the only SSRI group, there might be some patients who might have started doing exercise after we started the study. To our finding, we didn't have any patient who had started doing exercise in the only SSRI group also. So this inquiry itself didn't act or motivate patients to start exercise. Maybe a clear instruction and a follow-up of these things, and also explaining them the benefits actually had a difference and helped them to do it, I suppose.
Another final question.
Yes, sir.
In general practice, when we do see patients with depression, we generally do give advice to people to do some exercises along with the medications.
Yes, sir.
When you do not encourage people who are under moderate depression to do exercises, will that cause ethical dilemmas? Because you do not do your job that you are supposed to do, especially because of the study.
Yes, sir. We generally advise behavioral activation and activity scheduling for patients. We counseled these patients and asked them to feel comfortable with the activities they want to keep themselves and as busy and occupied, but we specifically didn't ask them or instruct them to do walking for 30 minutes for 3 times a week. So this particular instruction was not given to the other group. Other supportive counseling methods and usual supportive measures were done for the SSRI groups, only SSRI.
Thank you, Dr.
Thank you.
Kailash. Okay. Then the next we call upon Dr. Shabiba Kailash to present again from Chettinad Medical College.
Good morning to the dignitaries on and off the dais. I am Dr. Shabiba. I am an assistant professor from Chettinad Medical College, Chennai. My study was a comparative assessment of emotion regulation capacity in depressive disorder with the finding from first degree relatives and the general population. Emotional regulation, it refers to strategies employed by an individual to influence the experience of emotion as well as the behavioral response to an emotion. This emotional regulation can be either adaptive or maladaptive, and difficulties in emotional regulation were implicated in many of the psychiatric disorders where it is linked to lack of adaptive coping, including depression, borderline personality, substance use disorders, etc. Depression is a common mental illness where it affects one's ability to perceive, categorize, and manage emotions. Those with depressive illness have limited capacity to understand their emotion, and they have difficulty to recover from negative emotions. These people also use a lot of maladaptive techniques in response to their emotions. Studies show that higher emotional dysregulation is there among first degree relatives of depressed individuals. However, there are only few studies depicting the emotional regulation in first degree relatives of depression patients, and also we could not find any published literature comparing the emotional dysregulation in remitted patients of depression, their first degree relatives, and also the general population. Hence, this study was done with an objective of determining the components of emotional regulation in these 3 groups and to compare the relationship between these components in these groups. So coming to methods, we did an analytical cross-sectional study after approval by the Institutional Human Ethics Committee for a period of 8 months. The study population were into 3 groups. First group was depressive disorder patient currently in remission. Second group was the first degree relatives of these patients, and the third group was age and sex match individuals for the patient group from the general population. We followed consecutive sampling method, and the sample size after considering for the power of the study and dropouts, we calculated it to be around 56. Considering the attrition rate, it was calculated to be 60 in each of the 3 groups, and a total of 180 participants were recruited into the study. Participants between 18 to 59 years who were willing to consent were recruited. Patient group, those who satisfied ICD-10 diagnostic criteria for depressive episode, and those who were in remission with an HAM-D score of less than 7 with no other psychiatric comorbidity were included into the patient group. First degree relatives of the patient group without any past history of psychiatric illness or family history of psychiatric illness except this patient group were recruited. The general population group, age and sex matched participants to the patient group without any past or family history of psychiatric illness were included. The tools used were semi-structured proforma for collecting the patient's socio-demographic and other illness-related details, and also the first-degree relatives and general population group also we collected semi-structured proforma details. HAM-D scale was used to confirm the patient's remission status and to exclude depression in other two groups. Mini international neuropsychiatric interview was used to rule out all other psychiatric comorbidities. We used difficulties in emotion regulation scale to assess the emotion regulation capacity. This was a scale with 36 items, and it was a scale which was translated and back translated for use in our study. There are no standardized cutoff values available for this scale, so we used ROC curve analysis, and the cutoff was found as 99. And the statistical analysis was done using SPSS software. Mean values between the study groups were compared using one-way ANOVA, and the mean difference was found with post-hoc analysis. P-value of less than 0.05 was considered statistically significant. Moving on to the results. The mean age of the study population in all the three groups were around 37 years. Though there were a majority of participants who were married females belonging to middle and high school education with unskilled or semi-skilled occupation from rural background and lower socioeconomic status belonging to nuclear family. This was the socio-demographic pattern which we found, but still there was no statistically significant difference found between the three groups. 86.7% of patients, 38.3% of first degree relatives, and 20% of general population had greater problems in emotional regulation, and this difference was statistically significant. And we also found family history of depression in around 28.3% of patient group. One-way ANOVA and post-hoc analysis showed that this patient group had significantly poor emotional regulation when compared to the first degree relatives and the general population group with respect to the total DERS scores and also subcomponent scores. These were the subcomponents: non-acceptance of their own emotions, difficulty engaging in goal-directed activity, lack of impulse control, lack of awareness about their own emotions, limited strategies which were applied, and the lack of clarity, emotional clarity. So, mean difference of patient group from the first degree relatives was lesser than when the difference was compared with the general population. Like here the mean difference between patient and first degree relative was around 22, and mean difference between patient and general population group was around 25. And there was no statistical significance between the first degree relatives and the general population group. Coming to the comparison between first degree relative and general population, first degree relative group had non-acceptance of emotions and lack of impulse control, which was statistically significant, whereas in patient group, all these subdomains were statistically significant when compared to first degree relatives as well as general population. Yeah, and depression patients with respect to better emotional regulation, they did not show any statistical difference in any of the socio-demographic or illness characteristics when compared to those with poor emotional regulation. And first degree relatives and general population group, they showed better emotional regulation in married participant in our study. We also found that children of depression patients showed significantly poor emotional regulation than siblings and parents of the depression patients. So this was marital status influencing in family, first degree relatives and general population. Yeah. Coming to the discussion, in our study, patients even while under remission had significantly higher difficulties in emotional regulation compared to first degree relatives and general population. This finding is backed up by previous studies which showed remitted depressive patients engaging in more negative emotional experiences and also using persistent maladaptive mechanisms which could be reason for future relapses in depression patients. Its early detection will help us prevent the onset of subsequent depressive episodes in the vulnerable population. 28.3% had family history of depression, which can be viewed as a risk factor for depression onset in vulnerable group in family members. In current study, we observed that significant difficulty was seen in terms of non-acceptance, difficulty engaging in goals, impulse discontrol, lack of awareness, clarity, and limited emotional strategies. Non-acceptance was higher in patient group followed by first degree relative. Thus, studies suggest that acceptance and mindfulness-based interventions could be helpful in depression management. Emotional awareness was impaired, which was similar to a meta-analysis finding. And higher emotional awareness may indicate understanding of when to apply new ideas, ability to explore alternative emotional responses, and a better ability to perceive feelings, which would help us predict the response of these patients to psychotherapy. There was also difficulties engaging in goal-directed behavior. Other studies suggest that altered reward sensitivity resulted in decreased goal-directed actions independently of mood symptoms. Children had significantly poor emotional regulation, and other studies also showed younger age individuals being more prone for poorer regulation. Strengths of our study in literature, rumination and reappraisal were the more widely studied strategies. Other strategies which were not frequently studied were also assessed in our study. And emotional dysregulation is seen as endophenotype for obsessive compulsive disorder, eating disorder. However, no similar evidence has been found till date for depression. And our studies met few of the criteria which could help us consider this as being an endophenotype. Limitations, we excluded other comorbid illnesses and personality disorders which could have also influenced the outcome. And patients who receive non-pharmacological management and along with medications were not differentiated. If these limitations are addressed in future studies, it would be useful. So to conclude, depression patients had significant emotional dysregulation, and the family member, the first degree relative group, also had significant difficulties in emotional regulation capacity. However, further investigation is required to consider this as an endophenotype for depression. Thank you. These are my references.
So when you take us depression, what are the scores that you took it up for HAM-D, right?
Yes, ma'am.
Less than or?
Less than or equal to 7, ma'am, who were in remission.
Who were in remission.
Yes, ma'am.
This included even recurrent depressives or only first episode depressives?
Mainly first episode depressives.
Mainly first episode,
yes,
but you didn't have recurrent, because when you have emotional dysregulation, you can have even recurrent depressive disorder who have this also.
Yes,
Then
ma'am.
you had encountered any such things?
The sample which we recruited we did not find any such
anything.
case, ma'am.
Any questions? Floor. Yes. No questions from the floor? There are no questions. I think thank you, Dr. Shabiba.
Thank you so much, ma'am.
The third presenter will be Dr. Pavitra from SCARF.
Good morning. I'm Dr. Pavitra, consultant psychiatrist with Schizophrenia Research Foundation, and I will be presenting our study on association between childhood adversity and psychopathological symptoms in young adults, a community-based study, a cross-sectional one. Just give me a minute. Childhood adversity is conceptualized as a multidimensional construct involving multiple underlying dimensions of experience, and the prevalence estimates for childhood adversity from studies across India has been variegated, ranging from 3.4 to 72%. However, a recent national sample study reported that out of every 3 children, 2 of them face some form of abuse. And a range of mental health problems have been known to be associated to childhood adversity, including depression, anxiety, post-traumatic stress disorder, psychosis, and personality disorders. And psychotic-like experiences, which is a subclinical variant of the psychosis continuum, including subtle hallucinatory symptoms or delusional experiences, have also known to have its effects from childhood experiences, even in the non-clinical population. However, most of these studies are from the Western population, and there is limited data available from Indian studies. And considering that India mothers about 1/3 of the young population, and also considering the wide range of prevalence of childhood abuse in India, it makes exploration in this arena the need of the hour. The objectives of our study was to estimate the prevalence of childhood trauma among young people in the age group of 18 to 24, and also to study the association between childhood trauma and its different subtypes with the severity of depression, anxiety, and psychotic-like experiences. This is a cross-sectional study that was conducted in 4 colleges in Chennai and was a part of a larger WIC study. And the study participants included college students in the age group of 18 to 24, and they were recruited after obtaining written informed consent from them. We calculated the sample size for a 99.9% confidence interval to be 1082, which was rounded off to 1100. The following measures were used as assessments, and childhood trauma was assessed using childhood trauma questionnaire, which is a 28-item self-report questionnaire which studies 5 types of childhood experiences, including emotional abuse, physical abuse, sexual abuse, emotional neglect, and physical neglect. The values were estimated on a 5-point Likert scale, and the continuous data was retained and also recategorized using these cutoff values, which was provided by the authors of the childhood trauma questionnaire. And anxiety and depression was assessed using generalized anxiety disorder scale and PHQ for depression. Higher scores indicated increased severity. And psychotic-like experiences were assessed using community assessment for psychic experiences, CAPE 15, which is a 15-item self-report screening tool which calculates on 3 factor structures, namely persecutory ideation, bizarre experiences, and perceptual abnormalities. Initially, the ethical committee approval was obtained, and all the assessments were administered using mobile phones in the classrooms, where RAs explained each question and also ensured the completeness of the survey. And data analysis was done using SPSS version 20. Frequency and percentages were used to represent categorical data, and mean and standard deviations were used to represent continuous data. An association between the exposure and outcome variables was done using Pearson correlation, and univariate analysis and multivariate analysis was done to estimate the association between the variables. A p-value of less than 0.05 was kept as statistical significance. As far as the results are concerned, this table shows the socio-demographic and clinical profiles of the participants, and it can be seen that the study group included near equal number of males and females, and the mean age in our study participants was 19.4, and the mean CTQ score was 50.1. The results showed a prevalence of 90.1% of at least one type of childhood trauma in our study participants. It was seen that physical abuse was highest reported and sexual abuse was least reported in 1.2%. There was also no any statistical difference between the type of childhood trauma that was reported by the male and female participants. This table shows that there is a significant association between childhood trauma and anxiety, depression, and psychic-like experiences after adjusting for gender and age. And when it comes to the subtypes of childhood trauma, it was seen that emotional abuse was found to have significant correlation with anxiety and depression in the multivariate analysis after adjusting for gender, age, and other types of abuses. And physical neglect was found to have significant association with psychic-like experiences. Our study showed that physical abuse was found to be most prevalent, followed by emotional neglect, physical neglect, emotional abuse, and sexual abuse. Overall, this was compared to 2 Western studies and 2 studies from India, which used the same assessment tools. And it was seen that the overall prevalence of abuse in our study group was higher, and also the prevalence rate from the other Indian studies were also seen to be higher when compared to the Western studies, which could be indicative of the strict child protection norms that have been present and in place in the Western countries. And it was seen that the Indian studies, including ours, showed a high prevalence of physical abuse. And this could be indicative of the social acceptance of physical punishment as a form of disciplining children and also as a way of went out used in adults. And the noticeably low sexual abuse rates can be reflective of the hesitation that the young population have in terms of disclosing sensitive information, which also has a taboo attached to it. We also found that childhood trauma had significant association with anxiety and depression levels, which has been explained from a neurobiological perspective as effects on the developing brain and also as effects on the HPA axis activity. And it is also seen that there are biases in the cognitive processing that have been reported favoring this association, especially the threat-related social information processing bias, emotional reactivity and regulation, and reward processing biases have been used to explain this phenomenon. And though physical abuse was highly prevalent in our study population, there was no any association with anxiety and depression, which could indicate the cultural acceptance of physical abuse per se, or physical punishments that have been used. On the other hand, emotional abuse, which was, though reported relatively lesser, was found to have significant association with anxiety and depression, which has been explained due to the effects on self-esteem and emotional regulation due to the internalization of the abuse. And when coming to psychotic-like experiences, this has been explained from the neurobiological pathway of reduced cortical thickness, dysregulation of cortical levels, BDNF polymorphisms, along with cognitive mechanisms that there is an attention to threat, like in paranoid delusions, where there is an anticipated harm from the environment, which has been explained due to the experiences that they undergo in cases of childhood abuse. And also the association seen with physical neglect has been explained from the points of insecure attachment styles that are seen in psychotic-like experiences when the population had early experiences of childhood trauma. So to conclude, this study shows that there is a definite association between childhood trauma and psychopathologies. And also considering the high prevalence of childhood trauma and its impacts on the psychopathology of young adults, it is important to first identify and also involve in early intervention strategies which can be focused from the points of specific subtypes that have shown severity in psychopathologies, as in it is important to also address the emotional needs in young adults with childhood trauma for probable better outcome. We understand that despite the high sample size of 1,000, our study was limited to urban setting colleges in Chennai, and it is required to also generalize these results by conducting further studies from different settings. These are my references, and thank you.
Doctor, one question. What is the novelty in your study?
Sir, it is important to notice that there was very few studies that we could find from Indian population which focused on this area. Though there has been information from Western population, we also need to understand, like when we come to India, we expect that like for example, we know that physical punishments are still being used, be it in schools or be it by parents, but however, we don't know how much impact it has. While that is highly prevalent, we also need to see that there is an emotional, we miss upon the emotional aspect, be it when we are considering the prevalence or when we are considering an association. So I know that there is not huge novelty when it comes to Western studies, but I'm saying that even in India, the understanding of this concept itself is further required, which I think was the reason why we took this up.
Okay, I just want to know what was the question representing the physical abuse, because the incidence is very high.
Yes, sir.
So just beating once or twice, you take it as a physical abuse and they respond it like that, or what was the exact question?
So the exact question, I will have to show it. I'm not able to recollect the exact questions, but it had a particular frequency and the intensity. Did you have to go to the hospital sometimes?
Okay.
Were questions that were also asked.
So when you mean physical abuse, you mean severe physical abuse, necessitating to go to the hospital because of physical abuse.
That is just one of the values. I mean, that is just one of the questions. But overall, the rates, if we can see the scores of physical abuse per se,
that's 90.
Was 10.9 was the overall reported value or severity of physical abuse as a mean score. So that was itself per se high, irrespective of what questions were asked. It also has questions based on frequency. It also has questions based on intensity. But overall, that is 10.9 itself shows higher physical abuse when compared to cutoffs.
Okay, because the incidence was very high, 90+%.
The overall incidence of childhood trauma itself is 90%, which has been contributed from physical abuse by itself, which could be reflective of how the younger population is also taking the physical punishments that are being offered either at school or either in colleges. And the other reason that we thought that it could be this way is because of the recall that they have. We are taking a very young population of 18 to 24, so maybe they have higher memory of how they were physically disciplined either at school or colleges, which could be reflective of how they've scored it.
Thank you.
In your introduction, you had said 2 out of every 3 children have had some form of abuse. Where is this reference from?
This is from a national study by Kank.
Do you have that in your reference?
Yes, ma'am. Child Abuse, India 2007.
Okay, and both your CTQ, your Childhood Trauma Questionnaire, and the K-15 are both validated questionnaires?
Yes, ma'am. We validated both of them and we've sent it for publication. It's not yet published.
Okay.
Any other questions from the floor? Yeah, that is, thank you.
Thank you.
Dr. Pavitra. The last speaker will be Dr. Suvarna J. Kantipudi from Sri Ramchandra Medical College and Hospital.
Good afternoon, all. I'm Dr. Suvarna. I'm an associate professor at the Department of Psychiatry in Sri Ramachandra Institute of Higher Education and Research. I'm going to present on feasibility and effectiveness of telebehavioral interventions in maintaining abstinence among persons who had past de-addiction treatment for alcohol during COVID-19 pandemic, a single-blinded RCT. The co-investigators for the study are Dr. Sindhu and Mrs. Aruna. I would like to introduce the context in which the study was conceptualized. We all know that alcohol is a major risk factor, not only for non-communicable diseases, but also for infectious diseases, trauma, abuse, domestic violence, and hospital emergencies, suicide. And it contributes to significant mortality and morbidity, as evident by the Global Burden of Disease Lancet survey in 2019. A review by Dr. Pratima et al. In 2021 have said that the COVID 19 pandemic has induced a lot of alcohol-related problems, and there is significant increase in alcohol-related emergencies. Owing to lockdown restrictions, we all know there was significant difficulty in accessing treatment. Even in tertiary care institutions, only emergency services were provided. The regular services were suspended. There is a lot of isolation, loss of job in majority of the population, more so in persons with alcohol use disorders, which could have contributed to increased stress. Definitely there is a need for safe and effective management. This was a scenario when this study was conceptualized. I want to declare that we don't have any funds to do this study, and I don't have any conflict of interest either. We genuinely wanted to know what is the burden of problem, what is happening to these persons with alcohol use disorders during the pandemic. So one idea which stuck to us was, we have a repository of people who underwent de-addiction treatment in our institute. We approached the ethics committee, we took the approval, we wanted to estimate the burden of problem among alcohol individuals who underwent de-addiction treatment in the last 1 year before the COVID pandemic. So we estimated the burden, and we have published that in June 2022 Annals of Indian Psychiatry. And 69% of the people who underwent de-addiction treatment in the previous year were in relapse. Then we thought we should do something for these individuals. We wanted to see whether a tele-based intervention would work considering the uncertain pandemic nature. We want to see if that would be effective, if at all it is feasible, and we proceeded with the study. We also wanted to do an impact assessment on stress and quality of life, because these are the additional things which would contribute to person's well-being. So we proceeded with the research question, whether tele-based interventions were feasible, and if so, will they reduce relapse rate among non-relapsed alcohol individuals when compared to treatment as usual during COVID-19 pandemic. As said, this is a randomized control trial. The inclusion were persons with a diagnosis of alcohol use disorder who underwent past de-addiction treatment, who have not relapsed. Exclusion were coexisting substance use disorder except nicotine, person with severe mental illness, and who have not consented. The study period was December 2022 to August 2021. A sample size of 26 in each arm was calculated based on the assumption the difference in drinking behavior with intervention as 35%, with an effect of medium effect size of 0.5 and an alpha error of 10%. We obtained the ethics approval. This is how the study flow chart looked like. We have a repository of 183 records of people who underwent de-addiction in year 2019. We excluded people based on different reasons. 122 were included in the baseline survey, out of which 53 were non-relapsed individuals who were considered eligible for our randomization. This is how the randomization looked. We did a simple random sampling. We did a random allocation based on computer-generated random numbers. It's a parallel arm study with a blinded outcome assessment. We delivered behavioral interventions for 6 weeks. We followed them for 6 more weeks. We have 2 individuals who lost a follow-up in the study arm, 5 individuals in the control arm. We repeated the assessments. And the intervention, what we have chosen was based on consensus with fellow psychiatrists and psychologists in our institution. We developed 6 sessions lasting for 25 to 30 minutes, audio recorded sessions, including psychoeducation, improving motivation, and also explaining craving-related management, relapse prevention strategies, skill enhancement, and mindfulness-based interventions. And the assessments were done using severity of alcohol dependence questionnaire, perceived stress scale, and WHO QL BREF scale. Moving to results. This is the baseline demographic comparison of the study arm and control arm, which shows no significant difference. So that means the randomization was perfect. The balance table proves it. When we evaluated the primary and secondary outcome measures, especially the categorical measures using chi-square test, we found that there is no difference in the study arm and control arm regarding the relapse status. However, if you see 79.2% of study arm subjects are still in non-relapse category, whereas only 59.1 were in control arm. However, in stress-related variables, there is a significant difference between people who received intervention and people who haven't received. Moving to comparison of continuous measures from baseline to follow-up in the study arm, there is no statistically significant difference in the severity of alcohol use scores, but if you see the numbers, yes, definitely they have dropped. Whereas perceived stress scale, there is significant difference from baseline to follow-up, which shows the stress has improved with our intervention. And different domains of WHO QL BREF scale, there is decline in the, there is improvement in physical quality of life, whereas rest other components of quality of life have not shown any significant difference in our study. When doing the same outcome, continuous outcome measure assessment in control arm, we haven't found any difference in SATQ scores. In fact, they have increased, but they're not statistically significant. Whereas no difference in perceived scores statistically, but again, you can see the increase in the perceived stress score, mean scores. The social quality of life and the environmental quality of life actually deteriorated in control arm. Moving to discussion, 79.2% of the subjects have not relapsed in our study arm, whereas 20.89% have relapsed, which shows that even with some psychological intervention, tele-based, still people could relapse. And whereas in control arm, 40.9% had relapsed. Though it is not statistically significant, it is worth noting that the relapse is higher in control arm. This could be because of access to non-pharmacological intervention was far more difficult during COVID-19 pandemic, resulting in difference in relapse rate status between subjects in study and control arms. 62.5% of subjects had low stress and 37.5% had moderate to severe stress in study arm population, whereas in control arm it is significantly high, 72.7%, which is consistent with many of the previous studies which have studied improvement in stress levels following telepsychotherapeutic interventions. This could be because of including coping skills, anger management, self-efficacy in our management intervention arm, which could also have reduced the stress levels. There is significant improvement in physical quality of life of subject in study arm at follow-up. There is no difference in psychological, social, and environmental domains. In control arm, there is deterioration in social and environmental aspects of quality of life. Again, this finding would be related to the relapse status. The control arm subjects have more relapse status, and it is well studied in previous studies that alcohol use disorder and relapse of AUD had been implicated in drastic decline in quality of life. The loss to follow-up is less in study arm when compared to control arm. The strengths is a randomized control trial, successfully randomized. We followed allocation concealment, which minimizes the selection bias. We have blinded outcome assessors. We use standard assessment tools. We used intention to treat analysis. The study has a lot of limitations. There is variation in time since de-addiction, which is around 12 to 18 months. The relapse status is based on SATQ scores. The subject may not be true representative of the study population, so it cannot be generalized to individuals outside the tertiary care setting with a fixed de-addiction model. We use subjective outcome measures. No objective measures like blood alcohol concentration or urine drug screening was used. The duration of follow-up post-intervention is very short. We have not accounted for pharmacotherapy. We have no measures to identify whether if they are digitally challenged. Complaints to intervention modules sent in the intervention arm were not assessed objectively. Individual factors like personality traits, family support, and social support, and pharmacotherapy, which could have assessed, were not assessed. To conclude, tele-based interventions are feasible, especially for COVID-19 pandemic-induced alcohol follow-up care. It has potential to provide treatment access to larger groups, which can reduce stigma and also financial burden. They have better acceptability among individuals with alcohol use disorders. They could be effective in improving stress in some domains of quality of life. These are my references. Thank you.
Any questions from the floor? Yes.
The relapse numbers by percentage seems to be very significant. Why it didn't produce a statistical significance? Because
Maybe it is because we wanted that effect size to be more. If that effect size would have been, we want the intervention to be effective if it is beyond this level of significance. I'll go back to it. So.
What was
The standard deviation is high.
Yeah. Non-relapse status, like almost 20% difference is there. Looks to the naked eye, it's
Yes,
very
sir.
significant. What was the statistical tool that was employed? And
We used SPSS chi-square test, sir.
I don't know. Okay.
So if there are no questions, I think we'll wind up the session. Thank you, Doctor. I think I congratulate all the participants for their floor presentation. I think I thank all the judges. First, that is who had sent me all their scores, because I was behind them asking for the scores, and they were patient enough to send me, and some of them had even sent why they had scored like that, and also thanks to all the judges. And here we had 6 floor judges. Thanks to all the floor judges who had assessed them. I think with this, the award session is getting over. So it was really a fantastic one, but it was really a tough one. I was telling, as a president, this awards committee chairman becomes so challenging rather than anything else, because we'll have to collect, then we'll have to send it to the judges, get their report back, again send it to the participants. So for what? So that is what that has happened. And it was a short time actually, 15/6 was the cutoff. And within this 2 weeks, I could think we could get all the comments or all the whatever marks from the judges, so we could present it. Thanks for all who had helped me behind the screens actually. Thank you.
Thank you, ma'am.
And I think we should give a big applause to Dr. Sabita, who was the awards committee chairman, and with all sorts of difficulties, she could make it out. Congratulations, madam.
With this, we have come to the end of this session, and it's now time to honor our chairpersons. May I request Dr. Amuda ma'am to felicitate Dr. Sabita ma'am. Thank you, ma'am. I now request Dr. Ganesh Kumar sir to honor Dr. Babu Bala Singh sir. Thank you, sir.
Thank you, everyone. We have an announcement. Please get your CME credit points from the Torrent stall after signing there, and the participation certificate from IPCA stall. The souvenirs and ID card could be collected at the East-West Pharma. The lunch is now ready, so please be back by 1:45 for the next session. Thank you.
The results of this award will be announced in the AGB. Okay.
Important announcement for postgraduates. Those who are planning to present their free papers, please check the group to know who are presenting at 3 o'clock today. And please inform your friends also. Thank you.
and assistants to call up the district mental health program psychiatrist or the team member. The social worker from IMH should call them up and say that this patient is being discharged from IMH, please do follow them up. That is what we are doing right now. We don't have any technology or app to track them. So that might come in the future. And as for the homelessness and the global context, we have found that 44%, we have seen them, it is always they are victims of robbery, theft, threat, and when women come up, we usually find them pregnant, sexual assault, and they have a higher risk of physical abuse and sexual assault also. And then the integration with, this is one study, and again let me also say, only when I was preparing for this talk, when I went through the paperwork, I found that wandering mentally ill, the research was very few, and they said 2 or 3 papers, one by Banyan, and one from NIMHANS, the Know the Unknown project, and another one of these. So in future, for my postgraduates here, and for the others here, we are open to any collaboration wherein we can put up more research papers from the Institute of Mental Health, because the volume of the load of patients that we see is not being put in research here, cause the same reason the resources are scarce, and when research or the work gets more priority. So then comes our challenges. So herein we'll talk the practical aspects of it. The practical aspects is when the Mental Health Care Act 2017 was what we are all clueless. There is going to be a mental health review board, a judge is going to come, a new psychiatrist is going to be there. So what is going to be our role before the board? And then there's also this cases of earlier, and even now I think it goes on in some districts, a person who can walk in will always be written in an OP slip, advised to bring a reliable attender and come to report to OP the next visit. And if the patient says I'm suicidal and walks in, advised to go home and bring a reliable attender. I don't know how many will go home and come back. So these are all the issues which is being solved through this review Mental Health Care Act. So what we say is, if some responsible citizen finds someone on the streets, brings them to the hospital, so what we can do, what we are currently doing is, we have a tie-up with the NGO, so we contact them, so they go and put on CSR and bring them. And as for the lot of discussion and conversations that's happening in the WhatsApp group as to why not an FIR, the FIR makes it it's time consuming, and as we say the resources are low, they also say we have our own problems. So please, if we are going to insist on an FIR, the census which I am going to show will decrease further. We won't have any patients or any responsible persons who want to bring in. Now the process is easier to the extent that we even get calls to pick up patients from their homes when they are aggressive, when they are not able to bring them, when there is an elderly attender with them. Why? Because earlier we used to say, we even went to court for a case wherein we appeared and said the case that was filed against us was, why didn't you go home and pick them up? And the answer that we gave was, they have to come into the compound of Institute of Mental Health. Till that only Mental Health Care Act 87 says, which it doesn't come now under. We report to the NGO, they go, then they bring the attender, if suppose they are suspicious, so that we verify with the case records, and then we say that they can be brought. So this is how we are doing it right now. This is also the same thing. And then comes when to discharge from the hospital. So the common hurdles what we face when we discharge from hospital, we place them before a mental health review board. And of course, if we track the relatives are brought here and they become the nominated representative and we send them. If suppose we are unable to track the relatives and the patient becomes well and he says, no, I don't want to stay here, well and good, we assess the capacity and we place them in shelters. If it is a young person, a man or a woman, wherein appropriate shelters are there run by corporation, that comes in the NULM, we can see later. We send them there and from there they can go to work in the morning and in the night time they can report back to the shelter. And if suppose the person does not have the capacity but at the same time in the least restrictive pace he has to be in the community, we place them, send to many homes. At present we have a tie-up around 27 NGOs with us. So we coordinate with them and we send the patients back home. And this is where we still need more support, like how to enable the social welfare benefits. Even now, today's Madurai Hindu, there was a talk by the collector of Theni district saying that 96% have got their UDID cards and only 4 more percent and the entire district will be covered. Now, then comes the question of just 2 days before the meeting, wherein, and of course, as usual, the discussion in WhatsApp, it says like the only district psychiatrist is overloaded. Of course, we have district psychiatrists in all the 38, maybe barring 1 or 2 districts which are newly divided, they have one psychiatrist to bear the load of it along with the satellite psychiatrist. So the psychiatrist question is, I'll ask the district psychiatrist question, what they are asking me is, how can a single psychiatrist go and see the home patients, every one of them, and what else work do I do? So I am being overburdened, I am being overworked, so why is this expected of me? So the answer is, we have addressed this issue to the Chief Secretary, and he has said, we will work as a team. So the DME side, the DMS side, and the DPH side will be working together to find a way to make the process easier. Once they get it, and once they get a pension, then we will be having the pension given to them, so that will be in their account, and it will be given to the home NGO who are taking care of it. And this is as per the Mental Health Care Act. The previous slides itself is just a pictorial one. And as per the earlier sentence which I said, the differences between 87 and 2017 in terms of wandering mentally ill, we never ask for judicial reception order. We don't insist on FIR, because then the process becomes difficult and we are losing our patience. And then comes this. So our chairperson also is a member of a TN draft policy for homelessness mentally ill. Again, it is the advocacy of various stakeholders, and Malayapan sir, myself, and DMHP Dr. Manigandan also is one of the members in the board which was constituted to address the homelessness issue. And they have brought about certain highlight, and it is put in the public eye, and it will be drafted and it will be as a policy in a few months to come. So this was the one that the main highlights of this was this. So everyone should be inclusive, community based. So what we are talking about? We are talking about access to the homeless wandering mentally ill, wherein they can walk into a kitchen, Amma Unavagam, even or Kalanyar Unavagam, not even that 1 rupee or the 5 rupees for the bread and all. They should get the chapati or the rice free, and they should have access to free spaces, and they should be provided lot more shelters to be brought about, and everyone should be involved. The panchayat, the municipalities, everything should be involved. So it's an intersectoral coordination that they are talking about. And again, it is the same thing. Of course, we have made certain points saying that we don't want more of stakeholders to be from outside, so that we can also be a part and monitor it. And this is one point put by a NGO paper which talks about x-axis and a y-axis. And if you can see in that right hand upside, it says it's a low user centered but at the same time high service integration. Example is a multidisciplinary specialist and a tertiary mental health hospital. It states, even though we offer so many services, we are still not user friendly, which I contradict and say that, and the same you can see the lower part of it also. It says just like that we can't conduct camps often and when and then say that it reaches the users. But at the same time, I think we have to open up more and get into the community, because any project that we say that we'll be a part of, the first answer, the first query that comes from our higher officials is, what happens to the stigma that I am going to mental hospital? What happens to the stigma? So what's the answer that I always keep saying is, sir, the stigma has to reduce only if we have more programs here, if you have only more projects here, if you have only more infrastructure here. So bring it to IMH and then we will destigmatize it. So this is the way it's going on. And this is the interdepartmental coordination in the current state in Tamil Nadu. So health and family welfare, we have the DMHPs, ourselves in the DME side, de-addiction centers, and the Chief Minister Comprehensive Health Minister scheme, which is being slowly improving. IMH itself, we are working it out, still in the initial phases, and the ambulance services of 1 or 2. Whereas in the differently abled department also, there are a lot of programs going on, and there are certain areas wherein we all have a fight as to this program should be in differently able and this program should be run by us. And we tend to fight more at times, wherein when the halfway homes came up, So this is the Corporation of Chennai Services, Shelter for Homeless, and NHM. I don't know how many of you know, NHM sponsors 38% of the DME fund. And DMS fund entirely is by NHM. And DPH also is taken over by NHM. And the NHM has been extended till 2026. So the literally an appraisal or our review meetings will be held by NHM in the future. As of now, the other departments' review meetings are also held by NHM. So this is how it's going on. So this is the Department of Health and Family Welfare. As we have the DMHP, in that, let me give you an update about how many mental health establishments have been registered. Government medical colleges 18 and private only 11 have registered. So those who are here and not registered, please register it so that it is there. And de-addiction, we have 255. And district mental health program, if the wandering mentally homeless are finding a home all over Tamil Nadu, it's only due to DMHP. Because in being in Chennai, there are a lot of NGOs. You don't find that much of a wandering mentally ill in Chennai. But whereas in other districts, it's mainly the effort of DMHP and the local NGOs there who play a major role in bringing about this change. So 104 also, if you see a wandering person, you can call up the 104 and they will direct to the district psychiatrist. And ECRCs is the brainchild of NHM and Banyan, which put forth it. And it is going on well in 13 centers. Some are government funded and some are NGO funded. And we have this census. It is run by all these various NGOs in all the districts. And this is a 102, the JSSK vehicle. This is also one of the innovative things that was brought in, and it is being run only in Tamil Nadu. This vehicle is being run only for delivered mothers, for drop-in vehicles. But in Tamil Nadu, it is being used to pick up wandering mentally ill and drop them home or to the NGO center. So this was also made because our administrators higher up feels that they have a job, that their role is to make this Tamil Nadu, not a single homeless person should be there on the streets. And this is what they keep saying to me also. And we also have the de-addiction centers. Why am I talking about the de-addiction centers? Because this is also one of the main reasons for the homelessness which we see in various studies. So we have one in Kadalur, Tirupur and Kanjipuram. Again, lot of dialogues over the posting of all these de-addiction center psychiatrists and the team that is going on. And then, of course, we have the TASPAC funded de-addiction centers. In all these areas, it's coming up. So we have a lot of post vacancies here. And then come the halfway homes, wherein we had the fight with the differently able department saying it's not our this thing, you have to run a home. And therein the fight ended. As you know, our higher officials told, no, you only have to do it, or else we both will do it. So we came to this, we both will do it. And it is being run in 5 districts. So what is this halfway home concept? The postgraduates must be aware of it. And there are various activities going on in it. But a lot more way to go. Because the halfway home in IMH, it is functioning to the spirit of the halfway home. The clients there have the independence, they have their own bank accounts, they have their own mobile phones, they go to work. Even the latest instant, a person went on a OYO holiday. He gave a permission letter saying, I have booked here, this is my OYO rooms, I am going to go sightseeing and come back after 2 days, so I am going on leave in my office also, I won't be in halfway home for 2 days. So that's the state of halfway home here, and they have their own bank account. But of course in the other districts, the halfway homes, all the activities that are done, the proceeds still go to the NGO of that particular district, which in future, once a UDID is issued, once they get their Aadhaar, once their bank accounts are open, it will go to them. And then comes the NULM, the corporation run shelters. So right now in Chennai, we have 53 shelters. This is a shelter concept that I am talking about, wherein in the night they can go and stay, morning they can go and work. And Department of Differently Able, we have this ECRCs and the NGO run rehab funded homes. Private homes are 25, halfway home as of now it's 5, but it has to be come up in all the 32 districts. And this is also a period of point of discussion over the DMHP psychiatrist and us, which will also include all the other departments soon. And Department of Social Defense runs homes for children, and these are all the number of homes. And in IMH, for all those who are from IMH, these are the post of IMH for you to think about it. And this is our halfway home in the background. And this is our program for, we have in the process issued disability cards. We have issued around 266 in the latest count. And this is a recreational activity. And Shraddha, we have sent patients to Shraddha. It's been run by, 2 minutes sir, run by Dr. Bharat Wadhwani, who is a Magsaysay Award psychiatrist for rehabilitation. So our patients go through Shraddha. And these are all a list of patients whom we have sent to Shraddha, Apnagar and Rajasthan. We also regularly coordinate with missionaries of charity, Shanti Bhavan, and all these other homes. And as the chairperson said, this is it. We have an obligation to feed the hungry, clothe the naked, shelter the homeless, and care for sick. And our role is to go on. And as for the question earlier and asked in the earlier slide as who will stand up for these, every one of us should. So thank you for the kind hearing. Thank you, sir.
Thank you, madam, for your excellent presentation, and it's a vivid, and it gave us a lot of good insight about the mental health services available in Tamil Nadu. I think we can have our questions and answer session at the last. Now, we request.
Excuse me, sorry to interrupt, sir. A kind attention. For those whose names have been included in the free paper presentation today, please get to Hall 2. It starts at 3 and ends at 5. Thank you. Thank you, sir.
Okay. We can go on to the next topic. Next topic is the successful mode of model of a successful model across the world about the rehabilitation of the patients. We know that the mentally ill patients, they have a problem with emotional, cognitive, as well as the social disabilities. Because of these problems, impairment in social, cognitive and behavioral issues, they are unable to earn for the livelihood. So they are subjected to become the homelessness or wandering mentally ill. So what we need to do a rehabilitation for the people so that they can live with the family, they can live with in a decent life. So what kind of the rehabilitation will be effective for this patient, and how it be going to be effective and make them to live in a very dignified manner. So Dr. Karthik is going to speak about that. Karthik, introduction slide. Yeah. Dr. Karthik is working as an assistant professor at Madurai Medical College, and he did his MBBS in Tirunelveli Medical College in 2003, and did his DPM in 2012 at Madurai Medical College. He has worked as a Nusilamiti Government Hospital, and he did his MD in Madurai Medical College in 2016, and he did his DNB in 2020. Currently, he is working as an assistant professor at Thane Medical College. Yes, Dr. Karthik, it's over to you.
Good morning, sir. I thank the organizers for providing me the opportunity, especially my teacher, Dr. Sukadev sir, for. Thank you, sir. This is going to be a very short presentation because the topic is very broad. I'm just going to give you the principles of rehabilitation that is used across the world, which will be useful for us. I just, again, I told, as Mother Teresa told, being unwanted, unloved, uncared for, forgotten by everybody, I think that is a much greater hunger, a much greater poverty than the person who has nothing to eat. Homeless person with mental illness forms a very unique set of people who are the most disadvantaged people in the society. What Mother Teresa has told is she had told for leprosy, thinking about other disabled people in mind. But homeless persons with mental illness, or HPMI as we go and say, are the most disadvantaged people in the society. I just want to have a different perspective. We have a perspective about homeless persons with mental illness. But studies across the world project a very different perspective. The way forward is to change the perspective. My presentation is going to be focused upon that. First, the outline of presentation is homelessness. We will define what is homelessness. We will give a statistics regarding it, legislations regarding homelessness, and implications. We will move on to successful models of housing for homeless persons with mental illness. We will focus on high-income countries and then on low and middle-income countries. The key rehabilitation principle used in both of these countries and evidence base for it, and a review of effectiveness of these programs so as to implement it in our setup. Homelessness. Madam covered most of the topic which I am going to. but we will add on to it. There are various definitions regarding homelessness all throughout the world. A universal definition is being promulgated, but we will go for some of the most common definitions that is being used. Living in an emergency shelter, temporary housing program, or habitation not meant for humans. This is the definition given by US Department of Housing for provision of social welfare measures. In European Union, 4 types of houselessness are being said. It should be roofless, houseless, insecure, or inadequate housing. In India, one definition is present, not living in houses. Houselessness is what we call it here. There it is homelessness, here it is called houselessness. Not living in houses, dwelling in unprotected or exposed places like footpaths, flyovers, and staircases or railway stations, etc. Statistics. On a given night, we think that homelessness is a very big entity. We are focused about homeless persons with mental illness, but both are not entirely different. In the due course of discussion, we will see it. On a given night, these many people are homeless in USA, Sweden, even in developed countries. One statistics in India says that 449,000 people are homeless. That's quite low compared to the 2011 census. These many people are homeless in developed countries. Up to 50%. Statistics says that it is beyond 23 to 80%. But approximately up to 50% of the homeless persons are homeless persons with mental illness. No reliable data is available from developing countries. But Madam quoted this study. This was a study done by Tripathi et al. From a North India-based, hospital-based study among 140 patients. It said that 90.7% had mental illness among the wandering mentally ill. Others had intellectual disability. It was quite unfortunate that intellectual disability was not considered as mental illness. So 100% of the wandering ill patients had mental illness. 84% were mentally ill before becoming homeless. There's a very important thing to learn from every statistics that is being presented. 84% of the mental ill, before becoming homeless, they became mental. They wandered out of the home just because of the mental illness. This emphasized the early comprehensive mental care in the primary care setup, as Madam told. There should be a consolidation of resources. The consolidation of resources should be outreached. Once outreached, that is not the end point. The outreach resources should be integrated with general health delivery systems. That is the most important point. Recovering homeless people is just an initial step in doing so. To prevent homelessness to occur, this is the final point which you can do. Because the treatment gap for mental illness in India, according to the National Mental Health Survey, ranges from 28 to 83% for mental illness and 86% for alcohol use disorder. Madam said that substance use is one of the important causes. If you are not going to treat, they are going to become homeless. It is no point in recovering them from homelessness and doing all other things. The point is to early identification and a comprehensive mental health care in the primary care setup. Tertiary care setup, we are more focused. It should be integrated into the society. We will go on to it. There is a rough estimate about the mental health survey, estimates about homelessness among mentally ill. Homelessness among mentally ill is 1%. 1% of all who are homeless ill will become homeless. Approximate figure. So why legislations? This is one of the most important questions that we are speaking when we speak about homelessness. When we think of a roadside destitute or a wandering mentally ill or a homeless person with mentally ill, we immediately feel sorry for him. That is the immediate response that you get from them. Right now, until today, it is like a charity. It is quite absurd to say that it's a charity. It's not so. Legislation endorses their rights. Why legislation? Universal Declaration of Human Rights says that right to housing is a fundamental human right. So every person has a right to housing. So that's so, more so, a person with mental illness has a right to housing. So it is mandated by law. The United Nations Conventions on Rights of Persons with Disabilities, India is one of the dignitaries for it when we have ratified with it. That is the reason why 2 of the acts were promulgated. One is the Right of Persons with Disabilities Act of 2016 and Mental Health Care Act of 2017. Both of these acts endorse the rights of the persons with mental illness. Especially, Madam said 2 acts. I will just focus on the section 19 of MHA. Mental Health Care Act says that right to community living. That is one of the important rights of mental ill. Right to community living. Subsection 2 says that it is mandatory for the states to reunite homeless persons with their family. Subsection 3 says it is their right to get treated in a less restrictive setting in their own community. These two words are present in law. Supreme Court has asked for a formulation of guidelines to union and state governments. Recently, it has asked for a complaints report on this. So no more it is a charity. It is a mandatory. It is a mandated by law. Every mentally ill person has a right to live in the community in which he resides, to get treated in that community, to reunite with the community, and the onus of the duty of doing is with the state. So it has become a law and the state is responsible for doing this. So it imposes obligations on the part of the union and state government to address issues related to rights of persons with mental illness, including shelter and housing. Shelter and housing is just one part of the rights of mentally ill. So what are the implications of these things? As Madam already said, national mental health programs, the objective is to promote mental health, to prevent disability, and to facilitate recovery. Of course, promote mental health is quite obvious. How do you prevent disability and facilitate recovery? Prevent disability and facilitate recovery are two interlinked things. Only when the patient becomes free of disability, he will recover. So, homeless persons with mental illness are at a double disadvantage. As a double disadvantage of both having an increased disability and a delayed recovery. So, that should be addressed. Decent housing is a crucial factor that makes a difference between health and illness. This line was taken from an article in American Journal of Psychiatry. I will explain it what does means. Decent housing is a very crucial factor. Properly implemented legislations play a key role in protecting the right of disadvantaged. As I already said, properly implemented legislations are very important for protecting the rights. Less restrictive, community-based interventions to be offered with a wide range of choices based on individual needs is mandatory. It is no more a choice, no more an offering. It is mandatory. The state is responsible to promote it, facilitate it, and provide it. That is the reason why all high-income countries have extensive programs for rehabilitation of homeless mentally ill persons. Still, we are behind them. We will see what high-income countries are doing and what low-income countries are doing. Programs in high-income countries, we will focus on two programs which are highly referenced, well-evidenced, and effective. One is the Housing First program of North America. It was widely accepted in both Canada and Europe. The Housing First program was initially done by a community agency called Pathways to Housing from New York, and it was extended all throughout US, and now it is in Canada, and European Unions also have endorsed this. The main objective of the Housing First program is supported housing. Supported housing is to provide secure, independent housing with rigorous, individualized case management. This is the most important word, without any prerequisites. In the next slide, we will explain it. Supported housing is the concept for this. It discards housing readiness concept of COC model. There are two types of models of rehabilitating mentally ill persons. One that we are using, and Madam has said, is the traditional model. The traditional model is called as a transitional model or continuum of care model. When you see a mentally ill patient, wandering mentally ill patient, or a homeless person with mental illness, we rescue them. We rescue them, engage them in treatment, make them house ready. We engage them in treatment, improve them, assess housing readiness at each point of time, then bring them to a quarter way home, halfway home, then back to the society. This is what we are doing. This is called as continuum of care model or transitional model, which is treatment as usual. But that is not the case. In US or UK and high-income countries, as already postgraduates used to know, assertive community treatment and intensive case management is being done in community mental health services. In community mental health services, there is a case manager in intensive case management. He follows the case in the community, he does all the things that is needed. It is very resource intensive, which cannot be done at all in low income and low and middle income countries. So assertive community treatment act and ICM are there. But we don't have it. We have DMHP, which addresses to some extent to all these things. But transitional care model is being followed for homeless mentally ill persons. But this is a change in perspective. They say house first. It is the most evidence-based and widely embraced and implemented in high-income countries. I will just explain housing first. When you see a mentally ill person, they say, house him first, house him not in a secluded place, house him in the community. House him in the community, monitor him, and go from there. Rapidly exit homelessness is the key there. When they rapidly exit homelessness, they establish housing stability within a period of 6 months. When housing stability is established, improvements in health and quality of life gradually occur, and it's quite inevitable, they say. So community integration and long-term recovery are much sooner, much faster, and much enduring. This is the concept in North America or Canada and high-income countries. When you find a wandering person, house him first, rapidly exit homelessness, because as I already said at this point, in this point, decent housing is a crucial factor that makes a difference between health and illness. So decent housing is very important for this. So establishing housing stability, improve health and quality of life, community integration, and long-term recovery. This is in opposite to continuum of care model. We are yet to adapt these models. The similar program followed in Australia is called as HASP program, or Housing and Accommodation Support Partnership Program. HASP, Housing and Accommodation Support Partnership Program. This is the point. There was one article in AJP which published in Australia in 1992, done by Cohen and Simpson. The article is titled Homeless Mentally Ill or Mentally Ill Homeless. It was a wonderful insight into homeless mentally ill or mentally ill homeless. They say that the dichotomy itself is illusory. The dichotomy that homelessness and mental illness itself is illusory, because both have a bidirectional relationship. Mental ill persons experience homelessness and homeless persons experience mental illness. So what they suggest is, de-emphasize clinical solutions. When we see a person with mental illness, we are more focused to treat. They want to de-emphasize clinical solutions and focus on empowerment, consumerism, community reintegration. That should be the focus. Treatment will naturally ensue and community integration will happen, is their proposal. And that is being done now in US and high-income countries. So it's quite simple. The consumer is the homeless person with mental illness. There is already community mental health services which provides ACT and ICM and crisis intervention. One person is the housing provider. The housing provider is providing the house to home persons in the community. It is also an NGO or a housing provider. One of the beauty of the program is the person pays rents, because they get social welfare measures, a lot of social welfare measures. They pay the rent. The security of tenure is provided by government. They won't be used, just because they don't get a house. They will check out of the house if they have some mental illness or some issues. Security of tenure is provided by the government. Psychosocial report is as always provided by the NGOs. So this is one of the program. And excuse me, this housing support program is not new, and Banyan has already taken up doing this program in a smaller scale in Chennai. That's quite laudable. But they have group housing. Group housing is one aspect of HASP. There are other aspects of HASP which leads to more independent living, because the level of supports are also being quantified. That is too much for us. Just focus on the principles. Indian models or Indians are not far away from it. We have very good Indian models. As Madam already remembered, ECRC is one of the finest programs for homeless persons with mentally ill. It was a very scientific, it has very good scientific validation. When we always speak about homeless person or mental illness, we tend to become, empathize with them and become charitable. That is the problem. We need to become more scientific. We need to become more aware about that. It is their right. We are here to provide it, and it's mandatory. The charity should go off. Indian models, Shraddha Rehabilitation Owners, Madam already showed Shraddha Rehabilitation, it's Dr. Bharat Watwani. It's a very simple and a very effective model. It was modeled on the guideline of already Maxas Award winner Baba Amte said it. It is a wonderful approach. He writes it as, Dr. Bharat Watwani himself writes it as, it is a compassionate approach to treatment intervention, socialization, and vocational empowerment. It's good. It's a compassionate approach. The rescue, we'll see it. Shraddha Foundation is focused on a single client definition. It's only focused on roadside mentally ill only, not on other rehabilitations. Rescue, protect, treat, rehabilitate, reunite, and follow up. This follow up is what he says that is the most important thing. The follow up of the patient after reunion is more important, because we'll see a study by Banyan in the later part of effectiveness of the programs. Excuse me. Until 2018, 5,180 patients were reunited with the patients. He says that recovery is possible in 80% of the patients. Greater than 60% have full and long-lasting recovery. So they were not treated. Lack of treatment is that. The treatment gap is due to only 3 years. There is a lack of accessibility, affordability, and availability. So all 3 years are being, they are being rectified in most importantly in our state. The other objectives is, there are 2 other objectives other than this treatment. He says that creating awareness that mental illness is a treatable ailment, and we can get away with mental illness it needs to be inculcated in the minds of the community. Awareness creation is more important. When he goes to reunite a patient with them, he conducts a awareness program in the local community, especially with the relatives, neighbors, everyone. He explains the causes, symptomatology, the biological perspectives of the mental illnesses, and say that they are treatable. Like this he is doing. And networking with other NGOs. NGOs in the sense, not those NGOs only those deal with mental illness alone. Homelessness is a broader concept. All NGOs who deal with homelessness need to be networked for treatment of homelessness with mentally ill persons. It is run by a charitable trust managed by psychiatrists, as Madam already told. One important point we need to understand from the Shraddha Foundation is the importance of teamwork. Time and again he emphasizes that in clinical settings we are just used with the psychologists alone. Their role ends there. It is the social workers, the psychiatric social workers are the most important cog in reuniting the persons with mental illness with their family. There's a dearth of psychiatric social workers. Very good social workers need to be trained for this. They are most vital for uniting the family. And he is running a charitable trust. One funny thing that he has wrote in his project proposal is, he trends entirely on charity. The greatest weakness, he says, that it's the lack of appeal to the common layperson in terms of empathy to the cause it represents. When you go and ask for a donation, we are going to rescue the roadside mentally ill person, they are not feel, if you go and ask for a hunger treatment, Akshaya Patra, if you go and ask for child protection or women empowerment, or that, they are more willing to donate. But when you are going and ask for a roadside mentally ill person, and one of the donors said that the cause is not romantic enough to donate money. And other than the Shraddha Foundation, the Banyan does some good research works and treatment of homeless person. We are just speaking about homeless person with mental. You should always focus. There are many organizations who treat with mental illness. Mental illness is a very broad perspective. But a homeless person with mental illness give a unique challenge. Banyan has 2 centers. Adaikalam, which is, they are making it from 93. It's a transit care center. And all these have different modes of operation. They don't operate uniformly. Now they have started group housing systems in Chennai, Banyan. Asha Deep of Assam, Chittadamma of Mysore. Madam has quoted one study from Chittadamma. Samarpan of Indore. And this Ishwar Shankalpa is one important. They deal exclusively with urban homeless mentally ill. Urban homeless mentally ill is the focus of Ishwar Sankalpa. And Anbagam of Chennai also focuses with women. Banyan also has a single client definition. They usually work with homeless women with mental illness. Their focus is on homeless women. Madam told about the state governments. Government initiatives for homelessness in India include Niti Aayog has done a Dina Dayal Antyodaya Yojana. National Urban Livelihood Mission is there. It has sections of housing allocated for disadvantaged group, especially for mentally ill persons. They are provided lodging with essential facilities. They can live along with their family members. with reduced rental supplements. So the National Urban Livelihood Mission is one such. Pradhan Mantri Awas Yojana also gives similar benefits both to the urban and rural population. Swadhar Grace scheme is by Ministry of Child and Women Empowerment for distressed women. Madam. They give transit shelter housing for women in distress. Yes, roadside women also are being accommodated in transit sheltering. Then they are moved on to Deen Dayal disability rehabilitation schemes. Deen Dayal National Urban Livelihood Mission by the Department of Housing and Urban Development. Deen Dayal disabled rehabilitation schemes by Department of Disabled Empowerment of disabled persons. As we have already have some homes. Manasa Kendras was done before by the government of Karnataka. It is not as elaborate or as big as ECRC. They are just producing transit care centers, Manasa Kendra. ECRC, as I already told in the subsequent security also will speak about ECRC only, so we are not going deep into ECRC. But it is one of the well-researched, at present well-implemented program which has a great potential to become. We'll just go through 2 slides in review of effectiveness. So why this effectiveness comes into play? Because we already said that state is mandated to provide all these things. So cost effectiveness becomes very important. Whether the public money that is being spent is useful or not. So 82% of in the NIMANS project, 82% are improved at discharge. 51% are integrated with the family. Clinical empowerment is positively correlated with the reunion, and intellectual disability is negatively correlated with the reunion. I will just ask you, Tim Aubrey presents a randomized clinical control for effectiveness housing programs, housing first programs, and he, after all research, he says that permanent supporting housing is the model name. Is moderate. Moderate is a very good, level of evidence. End homelessness significantly and rapidly. He says that housing first ends homelessness significantly and rapidly, produces greater psychosocial benefits than useful. Banyan study says that homeless mentally ill. You can just go through this. The most important thing is the aftercare. As already shared in Shraddha Foundation, 84% adhere to treatment aftercare. They provide free aftercare treatment also. This is just finally, Roshan Heck, he has done an extensive review about housing first program and homeless mentally ill housing over the course of years. He has published 2 articles, one in General Archives of Psychiatry, the other in the AJP in a span of 7 years. So he has reviewed it, and in the latest article it says that transiting from research to practice, supported housing results in superior housing outcomes than treatment as usual, but moderately increases societal costs. Specialized intervention have significantly improved outcomes, most consistently in the housing domain, also in the mental health status and quality of life. Innovative programs are effective, but invariably increase costs in many cases. But at the last he says that their value ultimately depends on the moral and political value society places on caring for its least well-off members. This is what we need to focus. He concludes his study with this thing. But the financial management, but the ground reality is far from satisfactory. The financial management report of 2016-17 of the NHM states that expenditure by states and union territories of the DMHP is less than a third of the approved budget in India. Our own Professor Jacob of CMC Vellore said, countries and cultures which claim to be civilized have a duty to break the cycle of mental illness and homelessness by caring for the most disadvantaged people of the society. Thank you. Thank you. Sorry for that.
Thank you, Dr. Karthik. Done an excellent presentation. What to do for a patient with homelessness, what to do, how to rehabilitate them, how to integrate them with the society, how they can lead a normal life. So he has expressed in an evidence-based presentation. Good, Karthik. Thank you. Next, we have a third topic. Third topic by the role of general practitioners, private psychiatrists, and NGO. We have more than 8 lakh people with homeless mental illness. Whether the government alone can provide a care for them, whether they can produce what kind of things they can do for them, only the government is enough. As I said earlier, there is a huge gap between the need of the mental ill person and the resources available by the government. Whether it's a mandatory for the NGOs as well as the private psychiatrists to play a major role in these people with the homeless mental illness. To talk about that, role of private psychiatrists in NGO, Dr. Satyamurthy will request Dr. Satyamurthy to come for the dais, and our Dr. C.R. sir will introduce about Dr. Satyamurthy.
My association with Dr. Satyamurthy is quite long. Almost for past 20 years, I know him personally. And in fact, his entry into the government service, when I was the state nodal officer for mental health program, at that time he took charge as the district psychiatrist of Kadalur. He himself amalgamated with the district mental health program. Now today, the Kadalur district mental health program is suggested as one of the finest programs in the country. He is creating an awareness, and he sensitized all the stakeholders in and around the Kadalur district, and he created the treatment facility. There is another important thing. Kadalur has got a very vast general hospital setup. In that, first he sensitized the administrators, colleagues, and he established a 10-bed psychiatry ward and 30-bed de-addiction ward, and now he has got a plan to start dependent psychiatry. Very soon he is going to start. Such an amount of dedicated work. One thing I can clearly tell, the success behind his work is 3 Ds. There is a dedication, devotion, and determination. With the 3 Ds, he is making a lot of changes in the mental health scene of Kadalur. Now he is going to talk about the role of private psychiatrists and NGOs.
At the outset, I would like to thank the organizers for this wonderful opportunity. And it is really proud and I'm really humbled to talk in front of my mentor, teacher in the field of community mental health, and none other than our famous Dr. C.R. sir. And we know very well that undoubtedly M.S. Challamuthu Trust is a role model for as a pioneer in delivering the mental health care in the state of Tamil Nadu. And the organizers have chosen the very apt chairpersons, especially for my subtopic. And for any budding psychiatrist, and he is really a role model, and we should emulate or evolve. He is none other than our Dr. Pani sir. With this kind words and introduction, I would like to move on to my topic. And the topic given to me is role of private psychiatrists and the role of non-government organizations. With the previous 2 speakers, I could able to say that there is no doubt with the evidence-based Dr. Karthikeyan has highlighted the role of NGOs in the delivery of mental health care throughout the state or all over the nations. So, before I move on to the topic, here I would like to present, this is a WHO format for the optimal mix of mental health services. If you see the apex of the pyramid, the apical thing is a long stay or facilities or specialist services where the complete core psychiatric facilities are there. Next come the general hospital psychiatric unit and the community mental health services where the district mental health program is operating. Now the district mental health program has still decentralized down to the PHC level with the help of a new post called outreach psychiatrist. But when you see the base of the pyramid, which is highly needed, which is called informal services, informal community care and self-care, which is to the larger extent done by the NGOs or non-governmental organizations. So, but when we talk about Apex 2 base, it is really a cost-effective when we think about implementing. But the most robust prototype model for the highly populated country like India, the district mental health program is the real community-based model which renders the mental health services throughout the country. So coming to the role of private psychiatrists, WHO estimates that the mental health gap in lower and middle income countries is as high as 76 to 85%. A significant proportion of patients are catered by private sector. According to the World Bank, out-of-pocket health expenditure in India was 85.9% according to the study done under 2013. So this statistics reflective of the pattern of healthcare seeking and services in the country. The private sector has helped in making mental health care available and accessible in many parts of the country. So the private psychiatry has boomed over last few decades in private hospitals, clinics and corporate setups which are mainly concentrated in urban areas. Mostly they are run by the psychiatrists who provide the services. Some of them also conduct inpatient services in hospitals and which are tightly regulated. They offer diagnostic services and pharmacological oriented management. Some corporate hospitals also have psychiatric outpatient and inpatient hospitalization. So I will be talking more for the role of MHNGOs. I will be concentrating for the private psychiatrists for 6 to 7 slides. So next comes what are all the type of establishments or the employment opportunity or how the role of the private psychiatrists, how they are being in the community. Like, see, whenever I talk about the private psychiatrists, they are nothing but many psychiatrists in the government side are doing the private psychiatrists. So there are the different areas of the establishment. One will be the individual clinics, which include general psychiatric OPD services and specialty clinics like CAP clinics. For example, our renowned child psychiatrist, Dr. Preeti, is running the CAP clinic at Neuro Foundation, Salem. And many owns acute psychiatric establishment like de-addiction centers, acute psychiatric hospitals, and CAP hospitals. One example would be like Dr. Preeti's Child Guidance Center and Hospital in Madurai. Apart from this OPD and IPD care, many of the private psychiatrists are doing as a honorary consultants or visiting consultant to many de-addiction centers and residential care homes. So very few run medium and long stay establishments. Most of the long stay mental health establishments are owned by non-doctors, NGOs and missionaries. So current need of the hour in the field of psychiatry is group practice. So this can lead to a medium and long stay establishment and residential care. Neglecting this need for caregivers centers the vacuum which is then misused by the entrepreneurs. So now comes what are the avenues for the private psychiatrist to incorporate, to get involved in the public-private health model. See, Government of Tamil Nadu is doing a wonderful services in all the area of the health, including the mental health. So these are all the projects apart from the tertiary care institutions, and so these are the projects initiated by the NHM, District Mental Health Program, ECRC, de-addiction centers and dementia care clinics. So it is a right moment to say that the pride moment to say this is the only state which has covered all the districts covered under the district mental health program. So now the 32 districts are covered under the DMHP. See, 10 years before there was a shortage of a psychiatrist. So we hired a doctor, a qualified psychiatrist to be a nodal person for the district mental health program. For example, in Tiruvallur district, we had such a model. But currently, we have more number of outcome of psychiatric postgraduates. For an average, more than 110 people are coming out every year. And out of this, around 80% of people are coming down into the government service. So we have surplus amount of psychiatric fraternity in the state of Tamil Nadu. So I would say the role of private psychiatrists to work in the public health model is negligible, I would say. So coming to the media and the private psychiatrists. In the past 15 years, there is a sea change occurred in the dissemination of mental health knowledge by utilization of proper the TV channels, social medias. So many programs which you are very aware that very few I would like to quote Dr. Anandan from Mindcare has demystified many myths and misconceptions through his own YouTube channels and the social media programs. And one of the very famous programs like Koti Tirthu Bidu Thodi by Dr. Shalini, exclusive mental health, women mental health care, which run for many weeks. And Dr. Ashokan has done a very great job in delivering the knowledge about the sexual health. And you know very well that in the post-COVID era, we have umpteen number of YouTubers. Private psychiatrists have started many YouTube channels and they have started conducting the live webinars through Facebooks too. So according to me, the one important challenge for the private psychiatrists, which I perceive, is establishment of the mental health delivery system, that is any OPD services or inpatient care services. So after the inception of the Clinical Establishment Act, for any consultation room or polyclinic, one-time authentication is required as per the Clinical Establishment Act. This require regular monthly payment for Biomedical Waste Management Agency. So next comes the very cumbersome task for a bedded services for a IP care. It requires air treatment, water treatment, pollution board, control board certificate with Biomedical Management Agency. It will range from 2,000 per month to the 40,000 per year. That depend upon the number of beds and the amount of biomedical waste generation done. In addition to this, we need to have a building stability certificate, local authority certificate, and fire safety certificate. See, at this juncture, I plead Tamil Nadu IPS, especially the task force of Mental Health Establishment Committee, to take up this issue to the highest level of bureaucracy. So, any establishment, implemented as per the guidelines by the MHA rules 2017, which has been approved or which got a license from the SMHA, should give the status of exemption. So this is my humble request to Tamil Nadu IPS Forum. So next comes the role of NGOs, how they have evolved for for decades. What are the roles or the different variety of roles being conducted by the MH NGOs. I will be talking again and again MH NGOs, that is mental health NGOs. So in 1945, when United Nations was formed, there were some organizations that were neither a part of any government nor for conventional profit business. Thus emerged the concept of NGOs. The UN Department of Public Information defined the NGO as a not-for-profit voluntary citizens group that is organized on a local, a national or international level to address issue in support of the public health. So as far as we have the data, by 2009 we have 3.3 million NGOs are functioning in India, and among them GuideStar Statistics India portal gives 10,000 verified NGOs and 1,600 certified NGOs. Now we are worried only about those who are NGOs who are doing the services in the mental health care. So before that, a few points in the mental health gap. We know very well the 15-16 NMHA survey and the national dearth in human resources and infrastructure necessitates decentralization and community-based approach to mental health care. So it is this gap is really occupied or by the MH NGOs trying to bridge, while the reach of their work cannot parallel that of the government's agencies. The quality of care and their efforts in reaching out to various stakeholders give them a distinct advantage. Their method of operation is holistic, and they cater to various needs in contrary to the model which is executed to that is called a medical model, which is developed or conducted in the public health systems. So this is the hallmark difference between the medical model and as well as the holistic model done by the NGOs. So we acknowledge that there are several NGOs actively providing mental health services across various sectors, but their work largely unknown, especially to the scientific and academic communities, as their efforts are not recorded or published. It is also important to recognize there are several NGOs such as those working with youth, homelessness, victims of abuse, migrants, and sexual minorities whose primary focus is not on MH, that is mental health per se, but they provide a vital service as enablers and the facilitator of the mental health within their area of work. So they are bridging in various aspects in creating the awareness, training the manpower, and all the and lobbying for the policy change, community-based research. They usually cater a community, a particular community. However, the work of some has spread to more than one center or geographical region. For example, Alzheimer's related Disorders Society of India started in Cochin, now spread to 24 cities. Similarly, Sangat and Banyan have also widened their base of operations. So the growth of NGOs in the recent past been aided by three concurrent factors. One is increased level of professionalization of NGOs, wider availability of international national funds, and arrival of secular NGOs, which is not at all religious with any spiritual or any religious activities. So how they have evolved in the past 40 years. So Medico-Pastoral Association was the first voluntary organization established in 1984, and they are pioneer in establishing the psychosocial rehabilitation. 1970s and 80s saw the evolution of various NGOs in different aspects of mental health, and after the enactment of MHA in 1987, the next 2 decades saw further growth of MH NGOs. But the breakthrough after the passing of Mental Health Care Act 2017, which is a human rights-based legislation, further opens new vistas in mental health care, including furthering the role of mental health NGOs. So, in the initial days, say in the 70s and 80s, excuse me, with water. So in the initial days, in the 70s and 80s, they were focusing mainly on the developmental disorders of children, early focus on learning disabilities to include autism, hyperactivity and conduct disorders. For example, Vidyasagar, a very renowned NGO, Sangat, Umid, etc. provide outpatient as well as the special school-based services. So next comes, and they are focusing on the substance abuse and the de-addiction programs. So in the 1970s and 80s, we know very well the pioneer in this de-addiction programs is TTK Hospital, Chennai, Trada in Kerala and Karnataka, Parivardhan in Maharashtra, Samaritans and Alcoholic Anonymous in many parts of the country, and National Addiction Research Center in Mumbai. See, the very innovative project conducted by the Dr. Chavan and associated in a series of work that explored the community-based treatment for substance dependence. They coined a name called CAMP approach. So what is CAMP approach means? They found a place which has a high prevalence of substance abuse in the community. So the group of people with the specialists and other people go there and camp there for a minimum of 2 weeks. They will be started doing the de-addiction program at their village itself. So the home-based de-addiction strategy was evaluated by Chavan et al. And found effective. So this is a very important slide. After the implementation of Mental Health Care Act 2017, there are so many avenues being developed for the role of NGOs in the different chapters. Chapter 1 to chapter 15. See, MH NGOs are empowered to start the MH establishments, and they can be a nominative representative, and they can be a part of the SMHA and the CMHA, and they can be a individual. They are empowered to do the audit for any kind of mental health establishments. I will be discussing in individually. So once they given the rights of starting the MH mental health establishment, in MHA 1987, the mention of MH NGOs is conspicuously absent. In MHC 2017, Section 2P defines the term mental health establishment to include any general hospital or nursing home establishment or maintained by government, local authority or trust, whether private or public, corporation or cooperative society, organization or any other entity or a persons. So this is how paved a way for development of more and more mental health establishments by the NGOs. Moreover, the surveillance and monitoring of existing mental health establishments. After, according to the chapter 10, and they are empowered to do an individual audit for any mental health establishments. So once they've given the right of starting the mental health establishments, though they cater the different needs of people with mental illness. Say, there are different establishments for mental illnesses and for the special population and for the high-risk groups. Say, they have started acute care facilities, de-addiction centers, and the most important thing which I would like to is, they have started the respite care and the caregiver training, which is the more innovative activity which is done by the NGOs. And coming down to the special population, I would like to highlight one important aspect, like the NGO for the older adults, dementia care. So, DEM Care is an important organization. It is a part of the SCARF India. They are doing the wonderful services in the clinical aspects and advocacy, and very important, they became the resource persons for conducting the 2-day workshop for all the DMHP psychiatrists. And recently one batch of 2-day workshop been conducted for the by the SCARF India, especially the DEM Care personnels. So, as I said, they can be a nominative representative according to the section 14(4)(e). And however, this is only a temporary basis till the concerned board appoints someone from the Department of Social Welfare or from the DDRO office. This becomes more relevant in a case of homeless mentally ill who often have minimal psychosocial support. Coming to the person with mental illness and MHNGOs, they can reinforce, augment, embolden the available public infrastructure by a public-private partnership. And see, the very innovative thing is with the limited available resources and the staff members, they are doing the innovative programs. One example will be the mobile telepsychiatry unit that is called STEP project, which is conducted by the SCARF India in Pudukkottai district. Such measures ensures that the MHNGOs act as a means of providing mental health for all. So now comes the different area of concern and what are the mode of operandies. Like what are the different modes, public-private model or exclusive private model, and what are the role of MGOs. And here I would like to highlight what are all the important NGOs. There are hundreds of NGOs are involved, but I have highlighted the very important NGOs in these areas. So when we talk about the right to access and mental health care and treatment, Sangat, Schizophrenia Research Foundation, Samadhana and Prasadana has conducted many activities. And when we talk about homeless mentally ill, and Banian and Shraddha, which was highly doing a remarkable job, which was highlighted by Dr. Karthikeyan. And their area of concern is right to protection from cruel, inhuman and degrading treatment. So, coming to the activism, yes, they can highlight any deficiency in the systems and file a public litigation cases to remedy and rectify the same. For example, Mental Health Foundation, which is based at the Bangalore. And as I said, they can be a part of the statutory bodies like a CMHA or as well as a SMHA. Yes, according to the section, chapter 8, 46, they can be a part of the SMHA as well as the CMHA. See, here the prominent ways of improving mental health care are through documentation and dissemination of relevant facts. 2 minutes, sir. Yes. And prominent ways of improving the mental health care through thorough documentation, dissemination of relevant facts and research and lobbying policymakers. And for example, SCARF and as well as WHO have conducted a collaborative study in India, and as well as Hans Foundation and Government of India have conducted a collaborative study. Yes, coming to the role of suicide prevention by the NGOs, we know very well the SNEHA, the pioneer in establishing the helpline. And they also lobby for the changes in the law and the work to reduce the stigma related with the suicide. And especially the decriminalization of suicide, banning and restricting access to the particular toxic pesticide. This study by SNEHA was conducted at Kadalur district and especially in the Katamanargudi Taluk, which was, the study was posted in the Lancet, which was well accepted, well received by the WHO. Yes, the government of Tamil Nadu have signed different activities in the mental health delivery with different MHNGOs. Couple of years ago, there was a memorandum of MOU between NHM and the DMS as well as the 10 NGOs in delivering the different types of activity like IEC programs, identification and disability benefits, so on. So a glimpse of activity by the SCARF India, and they have collaborated with 2 or 3 DMHP in delivering the different aspects of mental health delivery system. Yes, coming to the CBR, community-based rehabilitation aims to meet the needs of person with disability, focusing mainly on health, education, livelihood, social integration and empowerment. See, when we discuss about the CBR, community-based rehabilitation, without the help of the concrete support from the NGO, it is very difficult to deliver the community-based rehabilitation. So this is the 5 matrix coined by the WHO: health, education, livelihood, social and empowerment. So this is the WHO model, how they can evolve the CBR model with the support of public-private model. The government will be taking up the health, livelihood, education and social, and the economical empowerment is the psychosocial rehabilitation will be done by the NGOs. One thing which I would like to highlight, one of the important project done by the MS Challamuthu Trust, this is called Udyog. I would like to read the important. தங்களுடைய மகள் உறவினர் யாரேனும் மனநலம் பாதிக்கப்பட்டோர் உடல் ஊனமுற்றோர் அவர்களுடைய சிகிச்சை பெற்று இருப்போது நல்லபடியாக தங்களோடு இருந்து அவரோ அவர் தம் குடும்பத்தாரோ வாழ்வதற்கு வேலை தேடி கொண்டிருப்பாரின் அவரின் நலன் கருதி வேலை வாய்ப்புகளை தேடிக் கொடுத்து அவர்களை சுயமாக செயல்பட வகை செய்யும் நோக்கத்தோடு MS செல்லமுத்து அறக்கற்று மறு ஆராய்ச்சியிலும் உத்தியோக் என்ற சிறப்பு வேலை வாய்ப்பு மைய அமைப்பின் மூலம் அவரவன் தகுதி ஆர்வம் மற்றும் திறமைக்கேற்ப வேலை வாய்ப்புகளை பெற்றுத்தர முனைந்து செயல்பட்டு வருகிறது. This is the real need of the hour. Yes, this is an activity which we are conducting at the Kadalur. For your information, before the implementation of the ECRC projects, it has been there for the past 5 years. Even before the ECRC, we have run this project as a prototype in the district of Kadalur with a collaboration with one NGO called Oasis. So initially there was 10 homes was aided by the government for the rescue operation of the wandering mentally ill. So after the rescue, the treatment will be initiated at the NGO home, and after the acute management, the treatment and the rehabilitation, this is for your information, so far in the district of Kadalur, along with the collaboration of NGO, so far we have reunited 400 people to the different states of people in presence of our district collector. This is a Shraddha Foundation. We collaborated for the reunion of the recovered individual with the family members. Some of the happy moments of reunion in presence of district collector. Yes. Critical evaluation. Yes. The paucity of trained staff and shortage of adequate funding. Of course, the lack of constant source of funding will lead to unemployment, and the NGOs may be used by unscrupulous individuals for illegal activities and money laundering, as donations received may be exempted from taxes. And meager number of MHNGOs itself act as a barrier to systematically study and build evidence of role of MHNGOs, and mostly they are urban based. And the next, it is a main topic for Dr. Ramanujam. I leave it to him, future directions. And I conclude, MHNGOs are undoubtedly required and have to be nurtured under appropriate regulations. MHNGOs should also document and their activities and process so that they can better monitor their own programs and facilitate the transfer of knowledge. So these are all my references. Thank you for your patient listening. Thank you.
Good elaborate presentation, Dr. Upti. Good presentation. Yeah. The role of a private psychiatrist and NGO is undoubtedly great in this mental health thing, especially the rehabilitation aspect. So NGO has dominated a role, especially in psychiatric rehabilitations. There are certain NGOs doing an extraordinary work, like which you mentioned, Dr. Sellamuthu Trust, and our SCARF, and also these our Snega, the suicide, they are doing an extraordinary work. If you see look at the mental health establishment registered under the state mental health authority, more than 60% of the mental health establishments registered under the state mental health authorities are by the NGOs. So there's a lot of things we have to discuss about that. Okay, sorry, sir. Dr. Sierra, sir will.
In fact, the mental health scenery of Tamil Nadu, the role of NGOs are very, very crucial and very important. For example, in the north, the role of Banyan, Scarp and Sneha, it is really noteworthy. And again in the central zone, the role of Atma, again our former South Zone President Ramakrishnan's the NGO, they are doing a wonderful service in the name of awareness, creating the treatment and also rehabilitation. Again in Madurai also in our trust. And again in Coimbatore and again Valigatti, again it is initiated by Dr. Selvaraju. And but not least, again in the south, Snega, my co-chairman, the Panir Selvam's organization, they are doing a really wonderful service, again creating awareness, free mental health services, community services, and also rehabilitation services. So, my personal feeling is, government doctors alone will not be able to address the needs of the mental health needs of the state, because the need is more, the service is less. So, private psychiatrists as well as government psychiatrists, and along with the NGOs, definitely if we combine and if we give a comprehensive program for the mentally ill, definitely it will going to address the total needs of the mentally ill. So thank you very much. And so far, 3 topics were Madam has, in fact, Madam has addressed about the current scenario in Tamil Nadu, about the mental health scenario, and Karthik, and he explained about the different models in mental health, and Satyamurthy, and he told about the role of private psychiatrists and NGOs. Now the question is, what is our next movement? What is our next plan? Because this is an imaginative, also innovative, the innovative topic, which is going to be addressed by none other than our Dr. Ramanujam. Please, I invite Ramanujam to the dais. To introduce Dr. Ramanujam, now he is the professor of psychiatry at the Tirunelveli Medical College, and he did his MBBS Tirunelveli, MD the Madurai Medical College, and also he worked in Thoothukudi Medical College, and he published 6 articles, and also he is an ICMR investigator. One thing is, he is a powerful media person wherein he is creating a lot of awareness, and he writes columns in newspaper, regular columns in Hindu, and author of 5 books on it, and quite interesting. And another hidden factor is, he is not only a mental health professional, he is a very good musician. நீங்கள் அவர் பாட்டை கேட்குறா இருந்தால் நம்மளுக்குள்ள டென்ஷன்லாம் போயிடும், அவ்வளோ அருமையான ஒரு இது. That is why he is very successful. He is tackling the government, the people, he is tackling the patient, and also he is tackling his wife. That is a very, very big, by doing the music therapy, he is really a wonderful person. And it is my great pleasure to introduce Dr. Ramanujam to the august audience. Now I request Ramanujam to speak about what is our future plan.
So, good afternoon, everyone. So, there is a saying that misfortunes never come alone. Like that. So, I have to speak something about community psychiatry in front of stalwarts like CRS sir. And that is one disadvantage. And the other thing is that I have to talk at the end of a session. I feel like a batsman who has to take some 1 or 2 runs and 5-6 overs are remaining. Nothing more. They say going through the emotion, just a formality. So my talk will be. And another misfortune is that this is the post-lunch session. So the misfortunes, and it is always persons who introduce the speakers, they speak very high and tell some white lies. Pacha pulugu jammu kaalathil odigina pulugu. Like that, sir he told one lie. He is able to tackle his wife abdina. That is one of the most unbelievable accolades that I have ever received. So coming to the row for mental ill, what next? So my topic will be more about just nothing. As sir said, this is just my ideas. I won't talk about much data or something, which beautifully they have, all the 3 speakers extensively and exhaustively they have done all the work for myself. So I just do. So we have a great, as everyone said, after if you listen to the 3 topics, you will be wondering what a beautiful service we are doing in our state. Of course, it is good. Dr. So many stalwarts like CRS sir is there, and madam is there, Purna Chandrika madam, and our Malayapan sir is there. They are doing a very great service. Private sector participation also, like Paneerselvam sir. We are giving a very good care. The DMHP is in all districts. And the wandering mentally ill, we have ECRC and other wonderful programs. We have a very good system. But is it enough? I always, there is a beautiful book called From Good to Great. So I always say, I don't want good students. I want great students. I don't want good things. I want great things. So we have to, can we move? We are doing good. So what we can do to move to a great level? So we always compare ourselves with the northern states. So compared to the Bihar or some other states we are doing. So, but why can't we compare with the Western countries and we aim as a great? So I will just highlight what are all the lacunas. Still, there are so many things that has to be improved in the delivery of the, especially my topic will be pertaining only to the wandering mentally. So as Mother Teresa said, the greatest disease is to be nobody to anybody. So being homeless is a great disease. And nearly 500,000 homeless people are wandering mentally ill. And not homeless, mentally ill people. So if you take homeless, that amounts to another thing. And one of the interesting thing is that we always focus on treatability. And many of the, as we know in our IMH and other experiences, that many of them, they have mental retardation. We find out that not only schizophrenia, so a practical thing that which we have to address. So if we want to improve, something should be done. And the laws are very vague regarding mental retardation. Even it is not included in the Mental Health Care Act, and that is someone we need to do something. What next? So we have to improve the state. What can be done for people who are mentally retarded? Because schizophrenia, we know it can be at least controlled, whereas mental retardation, this has to be the rehabilitation, and social rehabilitation is going to be the only thing that we can be done at the maximum. So many of them are wanderings, and the private. So mostly, when it comes to mentally ill, wandering mentally ill, the onus is mainly on the mental health care establishments, the government establishments, and private NGOs. They are doing a good job, very good, but still they need government support. So the onus is mainly on the government establishments. So the government has to. And 15% of the people with homeless, severe mental illness are homeless. So this is the surveys that say, and as everyone said, the National Mental Health Survey said that the treatment gap is 50%, nearly 50 to 80%. And many of them are, and homelessness is a serious problem, and wandering mentally ill. And so one important thing that I want to address is that we always talk about mental illness. Of course, we do a lot in mental illness. And one important thing in wandering mentally ill that we have to focus on, in majority of them have comorbid physical illness. So in fact, 80% of the patient, they have significant comorbid physical health problems like infections, so many people. And it becomes a very difficult problem when a person, say for example, a person with wandering mentally ill is brought, he is having a congestive cardiac failure or a severe septicemia, where he has to be admitted. He has to be admitted in a medical ward. But we know from our experience, in medical wards, they don't admit wandering mentally ill, and he has to be either admitted in a medical college hospital, where the facilities to treat unknown patients are very much less, or in a setup like the ECRCs. So this point, so as one point, as I said, mentally retarded. The another point we have to take is that the comorbid physical illness. This is going to be, so this is not only the problem with the involving psychiatrists, we also involve physicians and other people especially. For example, women problems. So we need to have gynecologists who can tackle the problems faced by the wandering mentally ill women. So this is going to be an important issue that especially sexual abuse, some of them may even become pregnant. And all these are some of the lacunas. We find so many gray areas in our setup. And when I am in a government setup, and only when you work in a government setup, we realize how much difficult it is. For example, a wandering mentally ill pregnant woman is brought, it becomes a nightmare to the department. So this was an Indian setup. Of course, we have district mental health program in all districts in Tamil Nadu. Of course, the newly created districts need. So another aspect is that coming to the diagnosis and treatment, we have to diagnose and treat without a proper history, because so many persons, we have a language problem. So when you see wandering mentally ill, they have they are from so many parts of the country. We commonly see, so people from other parts of the country, they just when a person becomes mentally ill and severely mentally ill, untreatable, they just board them in a train, and many of them come here, and we have so many language barriers. So these issues are an identity problems. We don't know their even names and identity and address. This has to be addressed. So these issues are now mainly our social workers are doing, but this has to be improved, and so many departments involved in this need to be integrated in treating the people with wandering mentally ill. So this is one important area where we have to improve, we have to focus. So we are doing good job, but these are all some of the, and as I said, the consultation lines. So where these comorbid physical conditions is another is an important task, whether they have to be admitted in a medical college hospital or a district hospital, where who physician has to treat. So this is our study. As I am a author of this study. This is a methodology for development of a community level intervention module for physical illness in people with mental illness. So this, as I said, the physical illness part of the mentally ill people, especially wandering mentally ill, is almost neglected. So this study was done in Tirunelveli. In Tirunelveli, we have what is called as an MRHRU, the Model Rural Health Research Unit. So there is a PHC in an area called Kallur. So that PHC covers 30,000 people. So we surveyed the entire population by door-to-door delivery survey, and we took all the severe mentally ill, psychosis and other severe mentally ill people, and we found out almost all of them, they have a comorbid medical illness. So many of them have anemias, and many of them have diabetes, and so many of them have hypertension. So we have suggested this model, CLIP-ME model. So the community level intervention, the district mental health program is addressing the mental health issues, but they also has to address the physical health. So, and another important thing, as I said, the government authorities should take into account. The majority of the persons, they don't have identity cards like Aadhaar card, voters, ration card. So this becomes a very big issue in running a mental health establishments. So these issues need to be addressed by the authorities concerned. So this and our members like our IPS task force has to take these issues into the authorities, so that there can be a special officers or somebody who can be deputed to look into these matters. So this becomes a problem when the patient becomes sick or dead. So, and all problems arise when the person's identity. So as we know, the biological, psychological, social model. So the rehabilitation also, we can improve the biological, psychological and social. So the most important thing, as we can say, so many times we have said, an ounce of prevention is better than tons of practice. So after the mental health person becomes severely mentally ill and becoming homeless, we are talking about it. But the most important thing that has to be done is prevention. So the prevention of a person becoming wandering mentally ill, that is going to be an important task. So how to prevent that? We have to do the area we have to focus. So we have to be, as I said, so many people are mentally retarded. So the health education and especially the stigma for mentally ill is only mainly because of the people who are wandering ill. So the person, the entire the society has a stigma about mental illness because of they are seeing people who are wandering in the streets in a disheveled manner, not taking care of themselves. So this causes the stigma in the mind of the people, and this has to be eradicated by one by health education, and other is by the early identification. And the most important thing that has to be done is the ensure that all people with mental illness they get a proper treatment. So this, if it is ensured, this can solve. So we are always delaying something, and after that we do. So what can be done? So it is, as we said, the roof, the topic covers the roof for mental illness. We always focus on when the roof is leaking, how can we wash the floor? That is how we will be planning. But before constructing a house, we have to make a foolproof roof so that it doesn't leak. So before a person becomes wandering mentally ill, the one thing that has to be done is the ensurement of proper treatment. So for that we have to reduce the treatment gap and integrate at the primary health center levels. And we have in medical colleges, we have special wards. It has been nowadays we have what is called as a 10-bedded ECRCs in every medical college. But again, there are so many limitations. So the same staff are asked to take care of the 10-bedded extra works. So the psychological, so rehabilitation. So the most important thing that we address, we treat them, and after treatment, where he will go, that is one important issue. So as addressed by the previous speakers, the halfway homes are all there, but still we have to focus on the occupational, and there are great service are done, as Satyamurthy said, the Udyog scheme done by our Chellamuthu Trust. So there are something, but this has to be done in a larger scale, and the whole state and the whole country, it has to be extended, so that people, once the person who become wandering mentally ill, he gets cured, what he will do, where he is going to do. This is one important area that we are lacking. So we have to address those issues, and what we are going to do for the occupational and vocational rehabilitation of that person. So we have to ensure through organizations that these persons get vocational rehabilitation. This is still we have to improve. So as done by the social part of it, still the involvement of NGOs. Now we are somewhere like a Trisangu Sorgam. So government and NGOs, and they do a good job, but still there are some deficits and in the coordination. So we have to, as I said, to reduce the stigma, the social aspects, we are publishing so many successful stories of people who have been successfully rehabilitated. And one important area that we have to take care in future is the responsibility of the media. So as Satyamurthy said, media has been once, it's very helpful, and so many psychiatrists are taking social media and they are promoting about mental illness and wandering. But one important thing is media also downgrades, especially if something happens in the mental health establishment. Media, the stories, then we have to talk to the media person, and still we get the WhatsApp forwards of stories about some mental health establishment where patients are cruelly treated like that. So we have to, this area we have to address, and we have to talk to the persons with media and ensure that they become a responsibility. And as we have the limitations, we have the resources. So one important thing is the integration of all the state. So many departments, they function in an independent way, and they don't have a coordination. For example, judicial department, police department, legal department, they lack the coordination. So we have to ensure that all the, I will talk to that in the final slide, about the integration of all the stakeholders, and even the legal authorities and the authorities concerned, they are not aware about the proper laws. So even it is very, very difficult to make one police person understand what is his duty regarding wandering mentally. So still we find that it is a very, very difficult task. So like what we say, naayivala nimitramari. So it is a almost impossible thing to make sure that these persons. So that is where we have to ensure. So we always talk about our responsibility and we are talking about our how to improve. But we have to involve. We have to ensure that people who have to do that job, they have to do, and they should not pass the responsibility on us. So strengthen the resources, involvement of NGOs and ethical issues. And one important aspect is and the rescue operations. So the logistical issues are very, very important when it comes to the logistics like ambulance and the rescue of the people and the helplines. We have helplines, but they are not of very much use. So the people wandering mentally, what to do? Even the lay public, they don't know. If they are find a person who is wandering ill, whom to call, where to, he has to approach. So even the people, even doctors, even people who are head of medical institutions, they don't know. Even it is sad that even deans or other head of the institution, they are not aware of what has to be taken by when a person with wandering mentally ill is brought. They just say, sir, doctor, please admit this patient in this general ward, like that. So this has to be, and as I said, the onus is mainly on the mental health establishment, and there has to be a coordination. So, and the mental health review board, still it is doing in our state, but still the role of mental health review boards has to be improved. So they have a major role in ensuring that the wandering mentally ill get a proper treatment. And even though they are doing their job, still it is only at the embryonic level at our. So in many districts, it has to be fully functional, and when it becomes fully operational, the wandering mentally ill has to be, the problem of wandering mentally ill will be reduced. And other departments like the social welfare and police department, they also need to be coordinated. Finally, coming to the educational aspect, we don't have as much research in this area of wandering mentally ill. So we need to improve the quality by doing a good quality research. What makes a person wandering mentally ill, or what are all the best possible solutions for people with wandering mentally ill? And almost we don't have proper research in mental illness itself because of the lack of resources, and the wandering mentally ill, it is still rare to find a good quality research happening, and we have to focus as an education aspect also. And there are so many ethical issues for doing the research in mentally ill, especially wandering mentally ill, whom to get the consent, and we have a lot of problems, and it has to be solved. So these are all some of the things, or these are all the areas I am just focused on. We are doing something good, but if we do something more, these areas, if we do concentrate and do better, we can develop a great care for wandering mentally ill. Thank you.
Very crisp and good presentation, Dr. Ramanujam. Now we call upon all the four speakers to the dais. So I'll hand over this mic to Dr. C.R. sir.
Now the session is open for question.
There are 2 points I'd like to clarify. When sir said about the more of social workers and all to be involved, Sharda Menon madam had this thought many years ago, and she said we have had enough of psychiatrists, so let us concentrate on the other cadre. So she was the one who brought up the psychology department and also Department of Social Welfare. And so she realized the importance many years back. And as for the Aadhaar card and difficulties, we are naming us, whoever will be the head of the institution will be the put on Aadhaar card. Once the address gets traced, we change the address.
It has to happen all over Tamil Nadu. Another thing, one important, madam has said, social worker, there is, we have started with, especially PP Kannan sir is here. So he has initiated what is called a mental health nursing assistant. So we have to develop paramedical staff who has to train in taking care of, it is not entirely a job of psychiatrists alone. So that is one area where we have to do improve.
Any question?
This is not about questions, sir. This is about sharing my views. We have been trained so well in dealing with the physical medicines, but after having completed 3 years in MD course, we understand that psychological health cannot be attained without attending to the social factors involved. But this point is very much missing in our curriculum, and we are all working hard. And recently, the last year Tanpsycon also, we had discussed about community-based rehabilitation. This year, a significant amount of time is allotted for community care of a homeless person with a mental illness. I think this is a very progressive step forward by our Indian Psychiatric Society. What I found missing in the presentations are, there are themes involved in running each institutions, and there may be rehabilitation homes being run by many people. Each rehabilitation home has its own themes. They have a focus in a particular area. Somebody is interested in giving training, somebody is interested in taking them to home, somebody is interested in, even though we talk about all the points, but each home has its own uniqueness, and professionals involved with these themes are also not professionals, what I would say, on record. They are all evolving, and we have not set standards for these professionals who are involved in this community care. In fact, we psychiatrists, there are many people focusing on each aspects of psychiatry. Similar to that, in rehabilitation psychiatry, there are multiple focus areas, and I think we have to pick up the threads, and we have to raise the literature in these areas, and we have to fine-tune and categorize these rehabilitation services. And we need more professionalism in handling this aspect of care, and the comprehensive care we frequently talk about, but this social care for the patients are missing and in need of the hour. I think it's a good thing that we are frequently discussing about this community care for our patients. Thank you.
Good evening. Representing General Hospital Psychiatry Unit. So as we know that ECRC is one of the well-established or evidence-based community setup treatment that is available in our state, and it is already being run in 7 districts, a separate ECRC with separate manpower and resources. But now in the last GO, say few months back, we have to give 10 beds in each medical college department. So I think most of the departments have a lot of difficulty in this. Rather than we are drafting a letter to the DME opposing this 10-bedded ECRC in a medical college institute, since creating separate ECRC centers in each district will improve the quality of care as well as provide job opportunities for the postgraduates who are coming out every year. Say 110 is leaving every year, but they don't have any job, as you all know. So it is better to create a separate ECRC center in each district rather than burdening the medical college with a 10-bed separately allotted to ECRC. Because we have a 20-bedded unit, if I am going to allot 10 beds, then managing the general psychiatry patients will be of great difficulty for each of the medical college psychiatry departments. So I think creating a separate ECRC in every district would be of great help, I think so. This is my opinion as well as suggestion.
Responding to your comments, Sudhakar, like initially the MOU of initiating the ECRC was developed by the government of Tamil Nadu. I've been taking into the account of what are all the districts who are already doing the rescue operation at their district level.
So they have taken the account of the NGOs involved or collaborated with the DMHP. So, for example, like Banyan came down to Kadalur, and they saw that already the project is going on for the past 10 years. So in fact, they are supposed to start the ECRC collaboration with Kadalur DMHP. But after seeing the collaborative activity happening with the DMHP and the NGO, that is called Oasis, they have shifted the base to some other places. So government initially assessed all the existing resources, and they have calculated where it has to be put, where the where need of the hour is there. So this is what I would like to convey to you.
I have another answer, Sudhakar. This will answer Ramanujam sir's presentation. He said that every ward, they have more of physical comorbidities, and that has to be addressed, and most of them are infested with maggots and everything. As you know, RGGH is running a 50-bedded ward, homeless for people with physical comorbidities, and also helps in tracing, and they are rehabilitating with NGOs. So what if this bed is placed along with coordination, not only in the psychiatric department, it can be pushed to medicine department with a goodwill and coordination. You have a lot of goodwill in Chengalpet. So if it can be pushed there, and we take care of them and we rehabilitate them, and you put that in the press and the public, and it gets more of publicity that Chengalpet Medical College is doing more. Definitely that is how it works. That's what I think, and GO has been passed, and the government thinks that it is the government's decision. None of us proposed.
That is what, because there is a lot of advantages when you have a separate ECRC unit, even in terms of providing job opportunities or...
Medicine opinion.
Madam, medicine opinion, you know what happens in a medical college setup. It is difficult even for a general psychiatry patient who is admitted in a ward that suddenly develops fever, say we suspect some meningitis or whatever it is, refer to the medicine ward, they will not take the patient. So this is the practical difficulty which we are having. So a separate ECRC unit in each district will be of a lot of help for the patients as well as the upcoming psychiatrists.
With a separate physician.
Including physician as well.
Madam, to add here, shall I?
Assistant Professor from Tanjore Medical College, Madam. So what I want to say, I'm just supporting sir's views only, because I've suffered a lot in this issue. In our Tanjore Medical College, they have given a name to this ward as destitute ward, unknown ward. Whoever has no attender or no physical health, maggots, nothing, means they say that psychiatrists should take care of them. 2 patients died in our ward without any care. So other ward staff nurses only are giving care. That too, they are telling this is an additional job for us. As per Dean's order, they are saying that's all, but nobody is taking full responsibility for those patients. We kept 4 patients, 2 patients bedridden, totally bedridden for 4 months in our ward. So it took a lot of pressure on our side to shift those patients to home. So whom should take care, who or all should participate in this? There should be a proper protocol before such schemes, I think. Though it is for the good of the people, but we the psychiatrists are suffering a lot, as people are thinking that psychiatrists are Jesus Christ, like that. You should take care of everything. Like that they are telling. So it's better to have a proper protocol, and as sir said, separate ECRC center will be a better choice, I think. Thank you so much.
One more suggestion which we thought is, suppose if the NGO has the role in identifying and rescuing that wandering mentally ill person, and if they are going to admit them in our unit, suppose what is the amount they say for them to identify and rescue that person and admit him in our center. Say they are quoting, say 30,000 rupees for a patient, let them give 20,000 rupees to the psychiatry department. We will take care of the treatment process, everything. 2,500. Suppose based on what they quote, ma'am. This is one of the last options. Suppose if you don't form a separate ECRC, then this might be considered.
Madam, about the point you made in RGGH. Yes, it's well functioning, and there are few issues yet to be addressed. I think I'm asking for Dean to organize a chiefs meeting in this regard, but still we are not able to. The thing is, the difficulty, this is related to Dr. Sudhakar's question. I think as it is given to the people, previously it was managed by community medicine professor, subsequently it is managed by geriatric department professor. I think everybody is participating. Rather than ECRC model, it's a good thing. And I think we can promote these kind of things. The problem, what I come across is, there are people who don't have capacity, but still they are in the ward. As per law, somebody is not having capacity, it should come under the purview of district review board. Unfortunately, we are in evolving process. So how can we admit a patient in a open ward? But I would always prefer to have that ward, because other medical discipline people, chiefs, are participating in the care of people. But how to address this particular issue when somebody is not having capacity but still in open ward, they do not know about the procedures. The missing person FIR should have been lodged when somebody is there for about 2 months or 3 months. I think these all need to be addressed.
To add on Dr. Sudhagar's comments, I would say whether the ECRC, whether run by the DMHP in collaboration with the DMHP, or run by NGOs, or run in a medical college hospital department of psychiatry, or exclusively run by NGO, there should be separate funding for ECRC. If there is no funding, asking the existing services to do the work of ECRC, the services will be inadequate. So now the medical colleges have been asked to do the work of ECRC without any extra funding, without any extra personnel. Even the, so that becomes almost asking to do something without the proper funding. So we have to plead with the government for separate funding. Whenever they start one unit of ECRC, there must be annual recurring expenditure should be sanctioned. So then they will increase to 5, 7 or 10 or 32 or 38 or 2 ECRC in a district, there must be funding. Annual recurring expenditure should be sanctioned by the government, and then only we will be able to give a roof for the roofless people. That's
Sir, initially in our district, we started with only one home, sir. After the regular performance and other activity, through the DDRO, through the rehabilitation department, we got 2 homes under the same NGO. But the problem, as you said very rightly, the amount given for running the 2 homes is very grossly inadequate. Now, you know that cost of living is very high. So for the food and the basic needs of the patients is not able to met by the NGOs. So this has to be sorted out in a yearly basis.
When a very enthusiastic and dynamic NGOs do the work as a model, they will be very much successful in one place. But when it is generalized to the entire state, there must be funding. So that NGO successfully running a model in a one place cannot be generalized without a funding. So funding becomes a backbone of this program.
Even corporation shelter, the daily thing is 22 plus 8 rupees for the person. If he stays back for a single day, even in the corporation shelter. So everywhere there is inadequate funding.
Yes, one more point. As the discussion evolved into cost effectiveness, I think the Banyan had published a paper about this community care. They had said about providing supportive accommodative care, as mentioned by Dr. Karthik, established in Kovalam. They said about 8,000 is required to rehabilitate these people in this particular supportive accommodative care. But we have been running so many institutions behalf of government, NGOs, but this particular cost effectiveness and the model which is best in this regard is yet to be published or to be discussed or to be analyzed from government institutions too. In that case, I think IMH would need to raise standards.
Actually, we had a meeting. Sorry, sir. Just 2 days back, there was this meeting with Chief Secretary when the review of Gaurav Kumar Bansal case, and on behalf of Banyan, Dr. Kishore Kumar sir attended it, and he again said the same point. We haven't verified it, that the home again, which is being run by them in 6 places in Tamil Nadu, they say it cost around 10,000 a month based on the income and all the other expenditures included. And they said that if this model is successfully run in all the districts, it will bring down the funding of the government also, and it will also be a little bit lesser fund from the government for all the other institutions, because this model is very successful. So we have to look into it.
Ma'am, one question, ma'am. Regarding the new medical colleges, currently 11 medical colleges they have been announced, and the basement, that is the psychiatry OP, should not be in the place where it is belong with other departments. I don't know why, because we have given in the underground. Actually, in the ground floor, we have given medicine department, surgery, and all other things. And in the basement, we have given psychiatry OPD. And they have been saying that it's because they have been given orders like that, only we should not. And also regarding the inpatient department, they have given us 30 beds, madam. And in between, there is no separate male and female. And there is a 4 feet wall is separating each and individuals. And there has been 5 bathrooms. There is no individual, because they're saying psychiatry department will be like that. And they have been received the protocols like from the higher officials is to be done in this kind of forms. Is there anything like that?
Even in IMH, when the PWD comes with me for rounds and they say, Madam, bathroom door podnuma enna? Neenga povingla, naam povona. So the same has to be for the patients. That's what I tell them. It's just that they have been working for many years, and earlier they used to build this community level bathrooms for mental hospitals before. So we have to continuously educate them, continuously tell them. If you are having difficulty in having this underground psychiatry OP, that we can represent and we can make it above the ground.
Topic is wandering mentally ill, and what you are talking is wandering psychiatrists.
And also another question, ma'am, regarding the ID card. The ECRC individuals, once we rescue them and after treatment, and the person who have been not taken all the other card, they can be based on the dean or institution, we are providing them. But many of the peoples have already taken Aadhaar card based on their retinal scan. The social welfare department is allowing that they can't retrieve back the information based on that scan. It has been given only to that ministry department, it seems. So they are rejecting, or they are not providing us the Aadhaar card, because only if they get Aadhaar card, they can arrange them that like crystals and that department can be done. So what can be done for that?
We also have that problem, but we are addressing it to the Aadhaar people, the persons who are putting it there, and we are trying to put a new card for them. If suppose it comes as duplicate, we are reapplying. We will contact you and we will tell you the procedure.
I think we had an extensive discussion about the burning mental health issue, that is homeless mentally ill. Last but not least, I want to share some of my ideas about this issue. We are talking about the homeless mentally ill extensively. But what is the reason why the people became homeless? One, lack of awareness, inadequate treatment facility, inadequate treatment doctor, high cost of treatment, long distance to travel, and also stigma. Even for a middle class family, keeping a psychiatric patient, it is very, very difficult. That is why they were not able to manage, and the homeless mentally ill become more. The fascinating thing is, so far in this social issue, we are addressing the symptom. We are not addressing the etiological factor. But in the past 10 years, definitely there is a little bit progress. We are creating the awareness. There are enough psychiatrists. All the district has got a treatment facility, and also even at the PhD level, we kept basic psychiatric medicines, and the cost of the psychiatric treatment has come down drastically, and to some extent with media's support, we are erased stigma to some extent. So what is the next? So far we have addressed we have given the basic psychiatric care. Our community, they don't get even the basic psychiatric care. So with the available facilities, we have given the basic psychiatric care. Now, every year, we are producing about 120 psychiatrists. And another thing is, already 500 psychiatrists are available in Tamil Nadu. Now, This is the time, so far we have traveled horizontally. This is the time we should travel vertically. This is the time we should develop specialized branches. For example, child psychiatry, adolescent psychiatry, de-addiction psychiatry, and community psychiatry, legal psychiatry. My personal anguish is IMH and medical college, the centers, there should be the research center. They should be the best treatment center. And other, the district headquarters hospital, they should address the community need. So this is the important need, future need. We should develop the specialized, poor conscious. For example, our government doctors who are working at the medical college, almost every psychiatrist, they are seeing about 100 patients. Are we doing justice for this? What is counseling? What is a family therapy? And simply we are repeating, repetition. And the patients also just like seeing a Venkateswara, just like a Tirupati, they are waiting for hours together and getting the darshan of psychiatrists at the last moment. Psychiatrists have a vacant stare. Patient has gotten another stare and nobody is understand. And with that prescription, there goes the pharmacy. The pharmacy people, they are giving some medicine. Somehow we are managing the whole show. This is the time wherein we should improve our quality services. It is my personal opinion. And are we doing any research, the quality research? Are we doing any impact program? I can understand it because the social issue always will be there. There will be always social issue. But as a clinician, we should not engulf ourselves in the social issues. For that, psychologists, social workers, other paramedical people, they will be there. And another simple and humble suggestion is, as a mental health professional, as a clinician, we should not put our hand in the social issues. Now, as I already told you, in anything in the government sector, any social issue, give them some counseling. The counseling is the common denominator for every administrator. ஏதாவது ஸ்ட்ரைக் நடந்தா கவுன்சிலிங், இல்லை யாராவது படிக்காமல் போயிட்டானா கவுன்சிலிங், எங்கேயாவது பேர்னிங் இஷ்யூ இருந்தால் கவுன்சிலிங். ஸோ counseling, everything. So in that, we are forgetting our ability. So this is the time, the future need is improve the research quality, improve the specialized branches, and improve the treatment facility, and also about the rehabilitation. Especially a developing country like India, wherein 133 million people are suffering from the serious type of psychiatric illness, with the 9,000 of psychiatrists, it is really impossible to give the treatment. So the community care, it is an alternative. So how to develop the community care involving the community? So ultimately, one solution is, without involving the community, without involving the treatment as a community treatment, I don't think we will not be able to do justice for the patient. So thank you, sir.
The homeless mentally people are they're underprivileged. They need a care of a psychiatrist, government sector, private sector, community, these NGOs, and they have to help them to live a dignified life. So as Dr. Sierra said, the community psychiatry is one of the important branch. We have a specialty section like a DM in child psychiatry, DM in geriatric psychiatry, even we have a DM in forensic psychiatry branches comes. But what we need is, we need a specialty section, DM in community psychiatry. Because what we do, we treat the patient, symptomatically we treat them and we leave the patients go away. But they need another aspect. They need to be, they have another thing. They have to reintegrate the community. We know that major mental illness, the patient have some kind of deficit. Even with the drug itself, many of the patients, more than one third of the patients become resistant to the drug. So what we are going to do? They have to reintegrate to the community. For that, they need a rehabilitation. The rehabilitation must. Many of us, as a psychiatrist, we as a private practitioners, we do acute care patients. But most of the patients, whether they have been completely recovered, whether they are doing a job independently, whether they have been live an independent life, we see for our clinic, for example, my clinic, almost more than 40% of the people, 40% of the patients, especially the chronic schizophrenic patients, they are not going for a walk. They will simply, they ideally be there in the house. So, வேலை பார்க்காம யார் வீட்டில் வச்சிருப்பா சொல்லுங்க? That is one of the reasons they're going for a wandering mentally and houselessness, the homelessness. One of the important reason is that we are not focusing on the other aspect, the rehabilitative aspect. And now many of us, we treat only the clinically we treat, but the patient need to live independently. So livelihood நம்ம தான் பண்ணணும் இல்லையா? So they only the person who become economically empowerment, that one the economically empowerment ஆகி அவனுடைய தன்னை தானே பார்த்தா மட்டும்தான் he can lead a good life. So that is very, very important. So from this we have to take another step. So we have to the rehabilitation psychiatry, the community psychiatry should be a major focus in future. With that, I conclude the session. Thank you.
Thank you, sir. Thank you, sir. With this, we conclude the panel discussion. It's time to honor the dignitaries on dais. We'll begin with the chairpersons. May I now call upon Dr. Ananth Krishnan, sir, to honor the chairperson, Dr. C. Ramasubramaniam, sir. Thank you, sir. I request Dr. Kanesh Kumar, sir, to honor the chairperson, Dr. C. Paneerselvam, sir. Thank you, sir. I now call upon Dr. Vidya ma'am to honor our speaker, Dr. Purna Chandrika ma'am. Thank you, ma'am. I call upon Dr. Ganesan, sir, to honor our speaker, Dr. Karthik, sir. Thank you, sir. I now call upon Dr. Balaguru, sir, to honor the speaker, Dr. Satyamurthy, sir. Thank you, sir. I now call upon Dr. Vetrivel, sir, to honor our speaker, Dr. Ramanujam, sir. Thank you, everyone. With this, the academic session have come to an end for today. The annual general body meeting will be held in Hall 2 from 6 p.m. to 7 p.m. Free paper presentations and PG quiz prelims will be held at Hall 2. We shall gather back in the same hall, that is Hall 1, by 7 p.m. for entertainment programs followed by banquet. Thank you all.